on behalf of Patel sir.
Okay.
Just give us a final countdown so that we can start.
Yes, ma'am.
No,
So we are live now, ma'am.
Can I start now?
Hi, Monica. I've joined.
Yes, ma'am.
Yes,
You
ma'am
can.
has
Hello,
joined.
ma'am. Hello, ma'am.
Hi.
Monica,
Good evening,
unmute.
good evening, good
Good
evening,
evening,
Sumitra.
ma'am.
Good
Hi.
evening. Good evening.
Hi. Lovely to see all of you.
Good
Yeah,
evening,
so
ma'am.
I think we can take Suchitra madam and Hemant sir's blessings, and then we can
Yes, yes.
start with Dr. Munjal's talk.
Right,
Yeah, so a
right.
very warm welcome to all the esteemed faculty members. This is the 206th episode of the Happy Learning series with Sogog in association with Ahmedabad, Gandhinagar, Himmatnagar, Mehsana, Palanpur, and Patan societies. And I'm very, very proud that we have our past president, Foxy, Dr. Suchitra Pandit Madam, today with us as our chief guest, and Dr. Hemant Bhatt and Chintan Thakkar, sir, as the guest of honor. Can we have the formal lamp lightning so that I can start the webinar, please? Thank you. It is my proud privilege to introduce our chief guest, Dr. Suchitra Pandit, Madam, for today. Madam is the most humble person that I have met.
Monica, just keep the introduction very brief.
Yes.
Just 2 lines, and that's enough.
Madam is currently the Foxy representative to FIGO, and she has been the representative to SAFOG in the last tenure. She's also a member of the FIGO Ethics Committee. She is a staunch follower even of the Justosis group, and she has been instrumental in designing the Justosis score. Um, she's seriously like a mother-like figure to me, ma'am. It's a proud privilege to share this platform with you, and the stage is all yours for the blessings, ma'am.
Thank you, Monica. Thank you. First of all, I would like to congratulate this full team of Happy Learning Masterclass, because I know you have been involved with Dr. MC Patel, and I'm very, very impressed that you're doing the 206th series today. So, first of all, hearty congratulations to your entire team. And secondly, I know MC, Dr. MC Patel, we call him MC usually in our Foxy circles, but Dr. MC Patel has been working very, very hard. And I think now this is time that we should support him wholeheartedly in his venture, for his elections as Foxy president. And here again, I would like to say that it's a good thing that whenever you're venturing out, you are looking at topics which are important. And the obstetrics is always going to be our bread and butter, no matter how much of endoscopy and how much of IVF we do, and now of course cosmetic gynecology. So I'm glad to see that the regular obstetric room topics like the postpartum collapse, the shoulder dystocia drills, or the cord prolapse is going to be taken, and there's going to be an excellent session where Parul and his colleague, they are going to be doing the moderation of the session. And of course, familiar faces, I always see Nita and Parth, because I know them from the team Ahmedabad. But Hemant Bhagat, Chintan, who are the guest of honors, then Rahul, Priyanshu, Uday, Jalak, Sanjay. It's nice to see everybody there and everybody join up together. And once again, congratulations to Dr. MC Patel, and all the best for a fantastic tenure. And the speakers, I'm sure you all will enjoy listening to Munjal, Dr. Patel, as well as Dr. Sushma. And Monica, congratulations to you officially now, as you have taken over as chairperson of the Public Welfare Committee of Foxy, and you'll be taking over from January. But you've always been working very hard, and all the best to you for your tenure, and all the best to Dr. MC Patel. And lovely to see all of you. Thank you very much for having me as the chief guest. Thank you.
Thank you. Thank you, ma'am. Thank you so much. With all your blessings, I'm sure sir will come out with flying colors and we are all with him. And I request Dr. Monica Gupta, madam, to please carry forward the proceedings and introduce our guest of honor for today.
Thank you, Monica, for the opportunity. And it is my proud privilege to introduce Hemant Bhatt, sir, who is a Joint Secretary of SOGOG. He was the President AOGS from 17 to 18, Joint Conveners SOGOG from 22 to 24, and Organizing Secretary of AICOG 17. Over to you, sir, for the blessings.
Thank you, Monica ma'am, and good evening to all dear Foxy friends who have joined this Happy Learning Masterclass. And it is very privileged moment when a 206th episode of the Happy Learning Masterclass is being telecast today through the Zoom meeting. I must tell that Dr. H.C. Patel, who will be our Foxy presidential candidate next year, he is one of the most pleasant personality, and he has the virtues of three P's. And that three P's are the patience, the perseverance, and the perspiration. A person who is conducting the Zoom meetings with so much of an academic knowledge that through all the subsections of our fraternity, like obstetrics, gynecology, medical legal aspects, ERTs, and whatnot, which has been covered through our Happy Learning Master classes. And this has always enlightened our delegates and the Foxy friends who have participated in these Zoom meetings. I wish my all the best to the Happy Learning Masterclass and especially the faculties for today. My dear Munjal will be talking about cord prolapse. Then there are other lectures related with the shoulder dystocia, obstetric emergencies is a panel discussion. And sudden obstetric prolapse is one of the best lecture I have ever heard from Dr. MC Patel in the past also. So there will be new updates also along with that lecture. I wish all the faculties also well for today's seminar, and I also wish all our dear friends who have joined today to gain as much as they can by participating in today's seminar. Thank you. Thanks a lot.
Thank you, sir. Thank you for your blessings. Please, now I invite Chintan Thakkar, sir, for his blessings. Put his CV. He is a passionate endoscopic surgeon. He is doing so much innovative work in laparoscopic surgeries and training most of the juniors. He is from the Civil Hospital Ahmedabad, and he is doing a private practice. And he has done so many community projects, presented papers on various regional and state conferences. And he was immediate past president Baruch OBGY Society and past president of IMA Baruch. Over to you, sir, for your blessings.
Thank you very much, Dr. Monica Ben, for those kind words of introduction. And it's indeed a privileged moment for me to be a part of this wonderful academic session started by our one and only Dr. MC Patel, sir. I can say our next Foxy president. But this is, or it's always a fun, attending such webinars, and it takes a lot of pain and a lot of hard work and a lot of patience, as Dr. Hemant Bhatt said, to continue this sort of academic programs, and that too up to a 206 number. So I welcome everyone here for this webinar, and it's always nourishing our brains and our academic aspect. So, and thank you very much once again for inviting me. At this moment, I would like to invite everyone who is present to attend our own SOGOG 2025, which is being held at Ahmedabad and on 19, 20, and 21 December. So, friends, please do join, and let's enjoy and have the academic fest together. Thank you.
Thank you, sir, for your kind blessings. Now I request Dr. Deepika to proceed further for the first session.
So, good evening, everyone, and thank you to Dr. MC Patel, sir, and Dr. Monica for giving me this opportunity. And thank you to our chief guest and guest of honor for giving us the blessings. I think Dr. Munjal, sir, the chairpersons are probably held up. I can't see them online. So, I will introduce you, sir, and you can start with your talk. Is that okay? Sir, you are muted.
Absolutely, ma'am.
So
Thank you so much.
yeah. So I think could we have the CV of Dr. Munjal, sir? So for our first session, academic session, we have Dr. Munjal Pandya, sir. Sir is Associate Professor, Narendra Modi Medical College, Ahmedabad, Gujarat. He has a diploma in minimal invasive surgery and has a fellowship in of ICOG. Sir is the president-elect of Ahmedabad Obs and Gynae Society for the coming year 2025-26.
Thank
And
you, ma'am.
he's the
Thank you.
president of Gujarati Book Club that he was discussing about. Sir, can we
Thank you.
have we welcome you for your talk on cord prolapse. Thank you so much, sir.
Thank you, ma'am. Thank you, Deepika madam, for your kind words. Thank you, MC Patel, sir, and the whole team of this masterclass for giving me this opportunity. I'll start the screen sharing. Yeah. So umbilical cord prolapse is something which is not so unusual thing. Anyway, in the era of having this concept of daytime delivery, we nowadays see a lot of such cases, and we all are actually trained, and we all are dealing with this normally. It's just brushing upon what we already know, and maybe something add up or add on towards something with that we know. So we know this definitions. Umbilical cord prolapse is something where the amniotic membrane is already ruptured and the cord is coming out. That's the simple definition. The other part is cord presentation, where the membranes will be intact. So if we actually decide or go for the previous terminologies, they had two terms. One was overt prolapse. Overt in French is also something which means open. So that's very simple to remember. So overt prolapse is something where the cord comes out before the presenting part through the cervix, and the occult one where the presenting part also comes out. Compound prolapse is something where cord will be there with the presenting part, as seen in compound presentation as well. And it is very critical because the amniotic membrane or the temperature within the amniotic membrane is quite higher, at least 2 to 3 degrees centigrade higher as compared to the external atmosphere. So whenever the umbilical cord comes out, it is exposed to a cooler atmosphere instantly. That will lead to vasoconstriction due to vagal stimulation, and that leads to sudden reduction in the blood supply to the fetus. And that brings to more chances of fetal distress and intrauterine fetal death. So this is a rough idea of what umbilical cord prolapse is, and which is usually seen in a lot of cases when the cervix is not yet fully dilated, and at the same time, for whatever reasons, the the amniotic membrane gets ruptured, and the sudden gush of fluid or amniotic fluid will lead to prolapse of umbilical cord. So what are the incidents? As per the literature, it is around 1 to 6 per 1,000 pregnancies. So again, not quite uncommon. And as we know that for us, it may be 1 or 6th pregnancy out of 1,000 pregnancies. But for that particular lady, it is one and only pregnancy for which she has been taking care. Not only she, but the family has been taking care of for last 9 months. So each and every child for that particular mother or family is 100%. So it's just not about ratio or a rate. It's about that particular pregnancy getting dealt with properly, having optimal neonatal as well as maternal outcome. So they say that at least around half of the cases, cord prolapse would happen within first 5 minutes of membrane rupture if the presenting part is not fixed properly or engaged properly. And that's where the importance of teaching and utilizing the knowledge of palpable fifth comes in. So all the teachers who are in medical institute should be teaching their students very well, because nowadays I think the reading part has been reduced with regards to the postgraduates. I think a lot of students are not purchasing the Williams Intellids. So that's where the responsibility of teaching with more efforts get in. And that's why the fifth palpable is very, very important, because if the presenting part is not fixed and membranes get ruptured, there are more chances of umbilical cord prolapse, and at least 60 to 70% would present within first hour. The trends are declining because a lot of factors are contributing towards a rise in cesarean section. So even before the cervix gets dilated to more than 3 to 4 centimeter, majority of the pregnancies are now terminated on via cesarean section route because of a lot of indications. And added indication nowadays, at least for last 1 decade, is maternal demand. Because now every pregnancy is precious, and every couple wants the guarantee of proper neonatal outcome. So declining rate is because of rise in cesarean section, but at the same time, we cannot deny that the neonatal outcome is also improving as well. So there is no particular definition where we can call cesarean section rate to be the perfect one. It has to be the optimal cesarean section rate for the best of the maternal as well as the neonatal outcome. Out of hospital, if the patient is out of hospital, there are 18 to 20-fold rise in mortality risk of the neonate as compared to the in-hospital care, because there are more chances that the per vaginum examination would reveal this diagnosis, and the patient would be majority of the times in lying down position or supine position, where cord compression will be less impactful as compared to the patient who would be walking out of the hospital, where the ambulatory position or even the ambulation would have more chances of cord compression between the presenting part and the cervix or the bony part. So what are the risk factors? There are a lot of risk factors where the presenting part may not be fixed at least before the rupture of membranes. The fetal factors are breech presentation because it will be a little bit spacious for the umbilical cord to come out, transverse or oblique lie, and that's why we would go for a cesarean section even before rupture of amniotic membranes. Non-engaged presenting part, which is quite important, and that's why clinical examination has to be supported by the fifth palpable or even mentioning of engagement of the presenting part. Multiple gestation, second twin after delivery of first one, because we are going to rupture the membrane after starting of citron drip, so that the presenting part of the second twin gets properly fixed before the umbilical cord comes out. Low birth weight, because we are not much sure of the circumference or the circumference of the head or even BPD. And preterm labor, where again the cervix is not yet fully dilated, the presenting part is not yet fixed, and umbilical cord may come out. And there are a lot of cases where we see asymptomatic bacteriuria and the presence of vaginitis, chronic chorioamnionitis, which may lead to rupture of membranes before the patient goes in labor. The maternal factors, polyhydramnios, we all are aware, and that's why we have that particular suspicious of ruling of diabetes, as well as controlled artificial rupture of membrane to prevent that umbilical cord prolapse. Multiparity, because at times she might go in precipitate labor, again increasing chances of umbilical cord prolapse. High maternal parity, abnormal presentation, because at times the umbilical cord might be just beside the placenta previa when the margin of placenta is at the internal os. When the cervix starts dilating, it may make away the space for umbilical cord. Fetal abnormalities, we know a lot of them associated with polyhydramnios as well as oligohydramnios, and PROM, that is preterm rupture of membranes. Iatrogenic risk factors, in 50% of cases, it would be seen as we discussed, artificial rupture of membranes. And that's why whenever we are going for ARM, the presenting part needs to be fixed from the above around the pubic symphysis part, so that after rupture of membranes, only the presenting part comes in and gets fixed before anything else comes in. External cephalic version, nowadays it is obsolete until unless it is associated with intrauterine fetal death, where we are not worried much about umbilical cord prolapse. Amnio infusion is again an attempt where there might be a problem with sudden rise in uterine pressure leading to umbilical cord prolapse. Cervical ripening in cases of larger balloon, but again, I'm really not sure whether it may contribute if the person is well versed with its usage. And fetal monitoring. So fetal scalp electrode we are not using, so we are not worried about this causes. Just they are there just to complete the list. What are the pathophysiology? Why we are worried about neonatal outcome? So when the umbilical cord gets directly compressed, the presenting part obstructs the umbilical flow, and that leads to sudden stoppage of blood flow to the fetus or to the fetus, and that's why there will be sudden hypoxia leading to sudden fetal death. The vasospasm, because of exposure to the external atmosphere, leads to vasoconstriction, and again that leads to sudden fall in the blood supply to the fetus. So everything adds up to the fetal bradycardia, which would be sudden, which would lead to hypoxic ischemic injury, lead to permanent disability if there is no fetal death. And that's why it is very, very important to have proper monitoring of fetal heart. So even if we keep the partograph or plotting of partograph, we have it is quite easy graphical record. We can train our staff to do the same. And that's where the prevention of such mishaps would be possible. So partograph is very, very important. It will be easier for us for medical legal support as well. It will be easier for us to explain to the relatives as well. So partograph and such documentations are very, very necessary when the patient goes in labor. What would be the clinical presentation? So there will be pulsatile code whenever we go for per vaginam examination. Fetal heart rate would show sudden bradycardia. They will not give us time, because routinely what happens is in non-reassuring fetal heart, in cases of fetal distress, we call it famously, if the baby passes meconium, that would be an indication that hypoxia has led to vagal stimulation, leading to opening of anal sphincter, leading to meconium passage, but everything happens gradually. First, fetal heart would lead to tachycardia, then there will be tachycardia bradycardia, and then there will be bradycardia, which might have a huge range of like a few hours at least. But in umbilical cord prolapse, there will be sudden bradycardia, and that's why it is very, very important to have abrupt action with regards to it. So there will be fetal distress, famously known as non-reassuring fetal heart sound, along with recent membrane rupture. So rule out cord prolapse immediately by doing per vaginam examination. There is no imaging help with that. PV examination is the only thing which would reveal cord prolapse. Digital examination would have the pulsation of cord. We need to immediately push our fingers to push the presenting part upwards. Preferably supine position is now to be given, at least to be kept till the delivery of the baby. And that's where we can prevent the cord compression between the presenting part and the cervix or any other part. At the same time, keeping that particular palm inside the vagina would prevent exposure of umbilical cord to the external atmosphere. So this is very, very important. And as soon as the uterine incision is kept, baby is delivered, we can remove that vaginal hand. So assistance or skillful assistance is very, very important. Differential diagnosis, fetal malpresentation might be there. So we need to be very much sure of palpating that umbilical cord pulsation. Placental abruption needs to be ruled out. Uterine rupture needs to be ruled out. And anyway, it is very easy because the tachycardia or maternal vitals will be reflective of a lot of things with regards to uterine rupture. Vasa previa is easier to rule out if we have done proper ultrasonography beforehand. So cord prolapse needs to be suspected and diagnosis has to be confirmed and on the spot, and action has to be immediate with regards to delivery of baby with aim of cesarean section. So current mortality is quite high, 6 to 10%. It is improved. It was previously around 50%. In low-income countries, it is still around 30%. Survival within 10 minutes is 100% if we take action and if we avoid any, even if the transient hypoxia, fetal hypoxia, the survival rate is quite high. So diagnosis to delivery time is very, very important, and access to emergency cesarean section in our setup is very, very important. And at the same time, as it is webinar of MC Patel sir, documentation is very, very important. Because whatever you do, if it is not documented and conveyed to the patient or relatives in real time, then the litigation chances gets high. Urgency-based based on fetal heart rate, if there is intrauterine fetal death, we cannot do anything about it. We can have our own time to take the decision for the route of delivery. But if there is bradycardia, most urgent step needs to be taken in form of cesarean section. pH declines significantly, and that's why if the CTG is applied, variable decelerations will be visible as well. Again, graphical record, useful for documentation. And intermittent compression would lead to reversible injury, but if there is permanent or longer duration compression, the injury or the neurological deficit will be irreversible. So these are the things we need to be explaining to the patient and relatives in real time. And that's why the staff needs to be trained. That's why the help needs to be, asked for from the fellow gynecologist with regards to such cases. So call for help, avoid touching the umbilical cord and do not allow the compression between the cervix or vaginal tissue and the presenting part. Manual elevation has to be there, and it has to be maintained before as long as we are not delivering the baby through cesarean section. And position of patient is very, very important. Knee chest position, so as the umbilical cord will not be compressed and the abdominal part will be downwards. So which are the ways? So one is a manual elevation or immediate manual elevation. The second part is bladder distension. So we can catheterize the patient and inflate the catheter and clip it or clamp it. But again, if we are subjecting patient for cesarean section, we need to catheterize again so as the bladder goes down. But at least for time being, we can avoid the cord compression by filling up the bladder at least with 500 ml. Maternal position is very, very important. A lot of options are there, which we'll be studying in the next slide. And that's why the knee chest position is very, very important. The other part is Trendelenburg 15 degree and other maneuvers. So this is a particular position where the cord compression can be prevented because the baby itself, due to gravity, will be going away from the cervix or vaginal region. And that's why knee chest position is to be preferred and rest of the steps to be kept as it is previously discussed. So this is the impact. Umbilical cord will not be compressed anyway without keeping the vaginal hand. And Sims position is one more position as well. We can keep a pillow when the patient is in prone position around the pelvic region, and that's why umbilical cord compression can be avoided. So assess the labor stage. If it is in first stage, there is no chance that this baby can be delivered vaginally without causing any damage because of cord compression. Go for cesarean section. For second stage, if you are really confident and skillful with regards to operative vaginal delivery, vacuum or forceps can be tried after making sure that the umbilical cord has been pushed up. So go for vaginal delivery if you are sure of it, that the baby will be delivered with lesser harm and in no time, or else go for cesarean section. That's the safest and most predictable outcome. People have tried tocolysis in form of terbutaline 250 microgram, but again, contraindications need to be ruled out before introducing any of the tocolytics. Instruction to the patient: stop pushing and avoid straining. Cord reduction is not recommended, associated with increased fetal mortality historically, and avoid additional procedures. So do not use any heroic efforts with regards to it. Just go for cesarean section or operative vaginal delivery, depending on the Bishop's score and your own skill and assessment of judgment or clinical acumen. So anesthesia selection and timing, usually we go for general anesthesia because it gives uterine relaxation, at the same time quick induction to delivery time. Epidural can be tried, but again, I don't think we are courageous enough to do that if there are persistent bradycardia. And multidisciplinary communication is very, very important, and neonatologist needs to be there present with regards to the resuscitation or effective resuscitation to get the optimal neonatal outcome. So decision to delivery interval is very, very important. Neonatal resuscitation is very, very mandatory or important. The equipments are to be kept ready. And now we have Laksh guidelines. A lot of setups are now Laksh certified, which has those equipments ready with regards to neonatal resuscitation. And all the charts are now there on the OT walls as per the requirement. Anticipated outcome needs to be explained to the patient and relatives, and follow-up is very, very important with regards to the assessment of the pH of neonatal blood, which will be done by neonatologist anyway. So how we can prevent? Obviously, prevention is the best cure. We can rule out those patients with maternal and fetal factors we already discussed, and then those patients need to be taken care very well. Per vaginal examination need to be gentle whenever we do. Avoid routine ARM in those cases. We have temptation of doing ARM at 2 to 3 centimeter dilatation, but again, which is not advisable because in the name of meconium, the cesarean section rate rises. And as my sir taught me, that intact membrane is intact baby. So even if the meconium is passed with the intact membrane, we are not going to have any problem because the baby is not yet breathing. So rupture the membrane when you have confidence of delivering the baby within next few minutes. And simulation training is very, very important with regards to obstetrics, because operative vaginal delivery is now dying art, is the cry of recent decade, and which can be prevented or washed away with proper training. So key management principles: urgent diagnosis is very, very important. Immediate decompression is very, very important. Expedite the delivery. Choose your route of delivery depending on your availability, your setup, and your skill. Team approach is very, very essential. There is no place of ego with regards to calling your fellow obstetrician that I need help. And prevention focused at management needs to be there. So I think cord prolapse is something which we routinely use, routinely take care of very well, all of us. And that's something which need to be transmitted to the future generations to have optimal maternal as well as neonatal outcome. So I think that's all from my side with regards to this topic. Thank you. Good evening, MC sir. Yeah.
Good evening.
What's the problem?
Thank you, Manjal sir, for an elaborate talk, and I request the chairpersons to please give their concluding remarks so that Patel sir could formally welcome all the delegates on the platform, sir.
I think there were no chairpersons. So
No.
I was just concluding sir's talk in the next previous webinar, sir. That is why I joined late.
but it was a wonderful talk, and lots of revision regarding the cord products has been done for the benefit of all the delegates who have been watching this seminar, and particularly importance of the quick action once the cord prolapse has been noted, and the importance of general anesthesia has been very well emphasized by Munjal. It was a wonderful talk. Thank you, Munjal.
Thank you, sir. Thank you so much, sir.
So, congratulations, Munjal. As usual, your talk is very to the point and very convincing, I would say. But
Thank you.
before we switch over to session 2, let me welcome you all, whether all have joined or yet to join. But I welcome Dr. Suchita Pandit. She had kindly consented to be chief guest to bless us. She is always with us to bless us in any of our academic activity. Guest of honor, Dr. Chintan Thakkar, President SOGOG, and Hemant Bhatt, Joint Convener SOGOG. They both are with me in our SOGOG activity, and both are very much positive to me as far as any of my academic activity is concerned. So welcome both of you. I also welcome all the learned faculty, Dr. Rahul Patel, Dr. Priyanshu Patel, Dr. Uday Patel, who had to chair this session, and of course Dr. Munjal Pandya. He has nicely delivered this talk of cord prolapse. I also welcome Dr. Jalak Shah, Sanjay Gandhi, Parth Shah. They are going to chair a very interesting session of shoulder dystocia, which is to be covered by Dr. Sushma Shah. I also welcome chairperson for third session, Dr. Prakash Joshi, Dr. Nita Thakre, and Dr. Vishang Patel. I also welcome two learned moderators. They are going to a very interesting panel, Dr. Parul Kotrawala and Dr. Sarfaraj Kaji. I also welcome Dr. Diliwala Jignesh, our treasurer of SOGOG. He is expert in this panel. He will give his expert comments during panel discussion. I also welcome all the panelists, Dr. Ishan Shah, Dr. Khemraj Chaudhary, Dr. Anand Chaudhary, Dr. Chirag Joshi, Dr. Naisargi Patel, Dr. Viral Luhar, Dr. Paresh Solanki, and Dr. Mahendra Soni. And of course, my team, Dr. Monica Omardan, convener of this series, and Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Deepika Logani, Dr. Satabdi Day, and Megha Kamlapur. They all are with me in this series, and they are working very hard to deliver this type of webinar every Tuesday at 6 p.m. So welcoming you all and all the society who have joined this webinar, Ahmedabad, Gandhinagar, Mehsana, Palanpur, Himmatnagar, and Patan. So President and Secretary of respective societies and all the delegates who have joined this webinar, I welcome you. As far as these labor room emergencies are concerned, we know when everything is going fine, and suddenly something goes wrong, and we are in a very big trouble, or it becomes a nightmare for us. So to revise all this situation, how not to face it, how to prevent it, and if at all it happens, then how to get rid of all this situation. We are inviting all learned speakers in our webinar to discuss all this, but ultimate goal is to check maternal mortality and infant mortality rate, because we, being an obstetrician, are directly concerned to check this. And as far as maternal mortality and infant mortality rate is concerned, by 2030, WHO and Government of India has given us a target that our maternal mortality rate should be less than 70. Of course, there are few states in India, they have already below this target given, but at the same time, there are few states still they are having maternal mortality near 200. And it's a, of course, matter of worry for all of us. And that is why we have to discuss all this situation again and again, and to be alert to deal with this type of situation, not to end up into any maternal or fetal morbidity or mortality. So welcoming you all again. Thank you very much.
Thank you, sir. It's an honor to be in association with you, and I would now request Dr. Nivedita Datta Madam to please carry forward with the second session.
Good evening, everyone assembled here, both as faculties as well as all the audience who's listening to this on the webinar link. This promises to be yet another very interesting topic after the first enlightening talk by Dr. Munjal on cord prolapse. So for this, we have three eminent chairpersons, and the first is Dr. Zalak Shah. The Secretary, Patan Obs and Gynae Society, is consultant of Rachna Women's Hospital, and she's interested in fertility, high-risk OBS, and improving women's health through preventive and postpartum care. The next chairperson for this session is Dr. Sanjay Gandhi, and his CV reads like a who's who, but he's an IVF specialist at DISA, the past president of Foxy Palanpur, and he's an IVF trainer, the organizing chairperson midterm SOGOG in 2023 at Mount Abu. He's a co-writer of books on IVF Made Easy. He's a faculty for IFFS International Conferences Delhi in 2016, as well as a zonal representative of SOGOG 2013 and 2015. He also runs IVF and embryology training programs and has trained 5 gynae doctors for IVF and 3 embryologists. The next chairperson for this session is Dr. Parth Shah. Dr. Parth is the secretary, Ahmedabad Obs and Gynae Society, the consultant at Seva Rural Hospital, Jagadia, 2011-2012, with a fellowship in endoscopy, gynae endoscopy, as well as interest in gynae endoscopy as well as fetal medicine. He is a visiting consultant at Resham Bhai Hospital, Ahmedabad, as well as Akanksha IVF Anand. He's been an invited faculty for Ian Donald National CME and the coordinator of AICOG 2017 workshop, and the faculty for lots of AICOGs and various other conferences. I call upon Dr. Zalak to please introduce the topic as well as the speaker. Dr. Zalak Shah.
Hello.
Yes.
Yeah, Dr. Zalak.
Good evening, everyone. Shoulder dystocia is many times anticipated and sometimes not anticipated dreaded complication of labor room. I invite Dr. Sushma Shah, Madam, who is Professor of Obs and Gynae at prestigious NHL Medical College of Ahmedabad. I'll request ma'am to start with the topic. Over to Sushma, Madam.
Hello, am I audible?
Yes, you are audible.
Yeah, good evening, sir. Thank you so much for giving me this opportunity to address this topic to such a wonderful audience. And can you all see the presentation? I'm sharing my screen. Is it visible?
Yes, ma'am. Yes, ma'am.
Yes,
Yes,
it
ma'am.
is. It is seen.
So, these are some of the very critical labor room emergencies, first described by Dr. Munjal so nicely, being cord prolapse and now shoulder dystocia. I would really like to congratulate sir that we are talking about normal labor, I mean vaginal birth, because now that I'm seeing more and more patients and doctors are opting for C-sections, and sometimes these questions will never come up. So I fear maybe 20 years down the line, these will again be topics of archives and not actual workplace. But anyways, this is one dreaded complication which we can hardly anticipate. So we all know what it is, right? But the classic definition is that when the head of the baby is born completely and the shoulders fail to engage into the pelvic brim. So what happens is the head is delivered and the neck is stretched greatly and the shoulders are still hanging above the symphysis pubis. Typically, you see it as a turtle sign. That is, the head is delivered, but it retracts into the vagina. There is no restitution, and you are very comfortably waiting that, okay, given another 10, 15, 20 seconds, and we are waiting for the shoulders to deliver, but that never occurs. And then it strikes, oh, this could be shoulder dystocia. So, I would like to describe it in two ways. One is you have already seen the patient antenatally. You know it is a bigger baby, slightly smaller pelvis is probably possible, or the baby mother is a diabetic mother, or there is some element of macrosomia. You are anticipating it, and here it is in front of you. A more dreaded complication is that you just don't anticipate it. It's a patient walks into labor, you know everything is going smooth and safe, and all of a sudden the head delivers and the shoulders are trapped. That is an even more panicky situation. Definition wise, head to body delivery time more than 60 seconds, but I know in the heat of the moment, every single second seems like an hour. So you are not actually counting seconds, you are counting your own heartbeats, and you are feeling the thumping of your heart inside your chest. Typically characterized by failure to deliver the shoulders. Incidence is 0.6 to 1.4%. But if you are anticipating a macrosomic or a high birth weight baby, that can go up to 4 to 6% as well. So this is what shoulder dystocia in a textbook picture looks like. So the head is delivered, the anterior shoulder is still stuck behind the symphysis pubis, posterior is somewhere inside or outside the pelvis. There may be entrapment of the cord, and the chest of the baby will definitely not be expanding. Now that the baby is outside, it has started breathing, it is taking the breath, but the chest cannot expand to support the breathing. So the baby is again going into additional respiratory crisis. And there can be severe brain damage if the blood circulation is not restored. Etiology is now, all this is theory, but the core question is, can we anticipate and can we act before it happens? So the only reliable anticipatory point is shoulder dystocia in the previous delivery is the only sure reliable predisposing factor. Besides that, if you have diagnosed a macrosomic baby and you know she was a diabetes mellitus or not, controlled irrespective. Now we all think that on ultrasound we can very fairly estimate the fetal weight, but as I browse through the literature, ultrasound, even at full term, even on the day before, on the day of delivery, even before induction, is not a very good and good estimator of expected fetal weight. Again, expected fetal weight does not definitely translate into a broader shoulder or a bigger baby, because it is also the soft tissue around the bony parts of the pelvis. A lot of people have tried different things, that is estimating the bisacromian diameter, but again that is more of a bony bony landmark. We are not, and then we surely don't know about the pelvis, because inside the bony pelvis itself there is the maternal soft tissue. So basically what I'm trying to say is that anticipation is helpful, but you cannot always with surety predict a big baby and predict a shoulder dystocia. So there is increased resistance between the vaginal walls. A large fetal chest is relative to the fetal head, and a rapid descent which prevents rotation. The time given for the fetus to rotate before the head delivers can sometimes end up with a shoulder dystocia, that is a precipitate labor. Now, so predictable risk factors, antepartum, of course, maternal obesity, excessive maternal weight gain, diabetes mellitus, controlled and uncontrolled macrosomia, postterm pregnancy. Very definite indicator is previous shoulder dystocia. Intrapartum factors being prolonged labor, induction of labor, and mid-pelvic instrumental delivery. As I went through literature, I could see that even if you induce labor in a diabetic patient, Just to prevent complications related to macrosomia, we may not be able to reduce the morbidity and mortality associated with shoulder dystocia. Similarly, if we attempt either a vacuum delivery or a forceps delivery with a head in the mid pelvis, that is station 0 or +1, what we achieve is we sometimes achieve the delivery of the head, but we stretch the fetal head and the shoulder might not follow through. So that it definitely increases the risk of shoulder dystocia. Normal mechanism is, of course, as the head engages, the shoulders lie at the pelvic brim. As the head descends, as the biparietal diameter goes on to +2, the shoulders are already inside the pelvis and at the level of mid cavity. So the shoulders enter the pelvis in an oblique diameter. They rotate and align the biacromial diameter with the AP diameter of the mid cavity, and it slips at the outlet. It slips under the symphysis pubis. Anterior shoulder is delivered. The posterior shoulder sweeps through the curve of the sacrum, and the posterior shoulder is delivered. Now, what happens when there is impaction? The biacromial diameter presents at the AP too early. The posterior shoulder may have passed the sacrum. Anterior shoulder remains stuck behind the symphysis pubis, and we cannot do anything about it now. We are stuck. The baby is breathing. The head is delivered completely, and the shoulders do not just budge. To the left is a normal mechanism, and to the right is what happens when there is impaction. Progressive as seconds pass, more and more congestion happens, and the baby also turns getting puffy and blue. Diagnostic signs, I don't think we need to know, but just to enumerate, the head is delivered, but restitution does not take place or happens only partially. Shoulders fail to deliver, even with maternal expulsive factors, efforts, and even with the standard gentle traction that the labor assistant will generate. The head recoils. The more you try to bring the shoulder out, the head goes back against the peritoneum after it comes out, and this is called the typical turtle sign. The differential diagnosis is almost not necessary. It could be a short umbilical cord, but no, even in a short umbilical cord, the shoulder will be visible. It could be a tight nuchal cord, yes, but then you could have seen the nuchal cord as soon as the neck delivers, or you can just pass your hand around the neck and feel the cord. You can even separate the cord between two artery forceps and you are through. There could be some undiagnosed abdominal or thoracic enlargement of the infant. This could have been a surprise element. It could be a locked or conjoined twins, that is extreme bad luck, and it could be a uterine constriction ring. This is more common with a very prolonged or induced labor. There is injudicious induction. There could be an element of fetopelvic disproportion, and this ring has been totally just missed. So the management principles are the do's and the don'ts. The first of all and the most important thing is do not panic. This is a situation and now you have somehow got to manage it. So first thing foremost is call for extra help from wherever and in whatever time you can get it. Instantly clear the infant's mouth and nose and see as much of breathing you can facilitate. Please involve the anesthetist and the pediatrician. Explain the procedure to both while working on the fetus. Follow the general principles of infection prevention. So once you are in crisis, everything else goes down the drain. So maybe in our setup, residents will just come in to help you. Somebody may be properly scrubbed. Somebody will have half gloves on. Yes, it is an emergency, but then you have to think of asepsis again. Do not panic. Do not give excessive traction. So no push, no pulse, and do not apply any undue fundal pressure. Okay, then what do we do actually? So there is a good acronym. This is called HELPER. H is immediately call for help. E is evaluate for episiotomy. By and large, you would have already done this, and most likely when you are anticipating a big baby, you would have already given an episiotomy, but then think of extending, is it a safe extension possible or not? McRoberts maneuver, the hyperflexion of the leg. Even if you're just, you're just anticipating, put the patient into this maneuver. It definitely does no harm. It facilitates the delivery. Give pressure, that is suprapubic pressure, but we'll come to that later. Enter, that is if this does not work, go in for different maneuvers which involve internal rotation. R is remove the posterior arm, and second, the last, roll the patient onto all fours position. If you look at the right of the screen, the first is the McRoberts maneuver. Most of the times, nearly 40 to 45% of normal shoulder dystocias are just taken care of by the McRoberts maneuver itself. Again, emphasizing for everybody working out in the peripheries without a huge team, just ask the patient to lift both the legs, get both the thighs as flush to the possible as to the abdomen. Maybe one of your assistants or even your ayah or somebody else, even the patient's relatives, can help keep the legs in that position. And you can concentrate on the baby and you can gently nudge out the baby. What this does is, we thought that it increases the diameters of the pelvis, but I found out it does not significantly increase the diameter. What it very effectively does is, it aligns the plane of the pelvic inlet along with the axis of the uterus, and it makes the force more effective. So, combined with the maternal expulsive force, bringing the fetus into the position of the inlet of the pelvis itself is just enough, and your crisis is averted. Next is suprapubic pressure. So remember, the shoulder is above the about the symphysis pubis. With the heel of your palm, locate the anterior shoulder and gently push the shoulder such that the hand adducts towards the chest. Try to bring the shoulder towards the baby's chest so that the bisacromion diameter shrinks even a little. The shoulder sometimes slips gently and the impaction is relieved, and you are able to disimpact the shoulders. This helps. In that case, sometimes you see the posterior shoulder first. You can deliver the posterior shoulder and gently the anterior shoulder is delivered. So there is no rule of the thumb that anterior first and posterior later. Whichever is easy, whichever is less traumatic, we have to go for that maneuver. Episiotomy, like I said, if we have not given an episiotomy, think of it, consider a safe episiotomy, whichever you are conversant. No definite right mediolateral or left, whatever your handedness, but please avoid midline episiotomies because there is a very high risk of this episiotomy extending into a full-fledged complete perineal tear, and we surely do not want that. So I would recommend a left or a right mediolateral. Lateral, I think none of us are practicing at all. Everything not working, one is this Gaskin, or it is called all fours maneuver. Immediately roll the patient over from her back into the all fours position. It is a very, very awkward thing to do, but it works. And exact mechanism, how it works is not known, but it is said that it helps to increase the diameters even by a small amount, and it helps to disimpact the shoulders. So this is the helper acronym, and these are the details. We have gone through all of that. This is what the McRoberts maneuver does. This is suprapubic pressure. So we have to continue the elevated leg position, and the heel of your the thenar and the hypothenar eminences, that should be giving gentle controlled pressure onto the fetal hand, so that it is like asking the fetus to shrug the shoulders. Sage diameter, thoda sa diameter kam hoga, तो shoulder slip हो जाएगा, and then probably the mid cavity is roomy enough to allow the passage of the shoulders. These are the internal maneuvers that we were talking about. So the classic wood corkscrew maneuvers and the wood anti-corkscrew maneuvers. Here we put in our arm into the vagina. I know this is very difficult. but still, I mean, it may have worked, but honestly, I have not been able to use these maneuvers. The point is, whichever shoulder is most accessible, you push the hand again towards the chest. So basically, we increase the adduction at the shoulder, and that disimpacts the shoulder, gradually rotate. So remember, there is more space into the posterior segment at the level of mid cavity and inlet. What we want to do is we want to utilize this space so that we are not crushing the baby while we are trying to deliver. Push the hand, reduce the bisacromial diameter, gently put traction, deliver the posterior shoulder and hold the baby and rotate it around half of the circle. Bring the other shoulder into again that posterior spacious roomy space and gradually deliver the fetus. So this is the corkscrew maneuver. Now, most of the times it works clockwise, but sometimes you have to improvise and you may need to do it in an anti-clockwise manner also. This is the other Rubin's maneuver. So here what to do is, whatever is the most accessible part of the fetal shoulder, you put pressure on it and you rotate that hand towards the chest. So we take the arm anterior from the side laterally towards the chest, gradually slipping the shoulder under the symphysis pubis. So basically, if you understand, what are we trying to do? We are just trying to reduce the biacromial diameter in some way so that we can reduce the presenting diameter and we can safely effect the delivery. The R of the helper is remove the posterior arm first. We discussed that because the posterior space gives you little more room for any kind of maneuvers. Remove the posterior arm first and then deliver that makes space for the anterior shoulder, and the anterior shoulder will be released from the symphysis pubis. The second R of helper is roll over on all fours. That the one, it is also called the Gaskin maneuver, and we have discussed, but honestly, I have never tried this one. The Zavanelli maneuver, which is classically what we have learned so far. So in a cephalic replacement maneuver, the cardinal movements of Reber. So here by Zavanelli, we are trying to put back the head into the pelvis again so that we can effect a C-section. Otherwise, you are stuck. You cannot deliver vaginally and you cannot deliver by C-section. So Zavanelli nowadays becomes important to know it because we are all, and especially the younger generation, is more confident and more trained for a difficult C-section than a difficult vaginal birth. So remembering all those mechanism of the labor, we reverse the mechanism and gently try to put the head back into the pelvis and thereby slightly push the shoulders up. But again, we must remember that we may have to extend the C-section incision, the incision on the uterus, to deliver the shoulders, because basically this is still a bigger baby and a large, bulky, chunky, impacted shoulder to be delivered. Of course, Zavanelli is performed on the OT table, and the next immediate step is you open up the patient, that is, you go into C-section. And so many times I have seen that we do not wait for any spinals here. It is just GA and you deliver the baby because the baby is already cyanosed, already asphyxiated, and baby is in a lot of distress. One of the very effective but very less practiced, how would I say, this is a rescue mechanism, is a symphysiotomy. I have just seen once one of our very senior professors effecting a symphysiotomy. It basically requires you to disrupt the symphysis ligaments, distract both the rami of the pubic symphysis, effectively opening up the pelvic anterior, the inlet, increasing the diameter and delivering the baby. But you may come out of that crisis, but after that, post symphysiotomy, life for the patient can be really difficult because it leads to osteotitis pubis and the patient lives with a swaddling gait, and the patient is in perineal pain, even sometimes during coitus, and it is a very tough situation. So for me, symphysiotomy is a little difficult to palate. Okay, before going to consequences, we must also learn cleidotomy. If nothing works, or we do not have a setup for an instant C-section, or the baby is dead or severely compromised, we may not want to give a scar on a diabetic mother. We may just have to make a cleidotomy. And though these instruments are museum pieces now, we have to remember you can do a cleidotomy by putting extreme pressure on the fetal clavicle because they are not so well calcified. Sometimes you can just effect, or you do have a cleidotomy scissors, but it is necessary. So we must all at least know about it and learn it at some point of time. So, what are the consequences? There are maternal and there are fetal consequences. The bigger sufferer is, of course, the fetus, but the mother nonetheless does suffer. The neonatal injuries very typically are the brachius plexus injuries, commonest being the Erb's paralysis. Clump case, for some reason, is not that common. Clavicle or humeral fracture, sometimes dislocation of the arm. Of course, asphyxia, acidosis has most of the times set in. This results into HIE, that is a hypoxic ischemic encephalopathy. Neonatal death is not an it is not an distant nightmare. To the mother, of course, there is a risk of all the tears. There is risk of PUTs. There is a risk of paraurethral tear, vaginal tears, extended episiotomies, hemorrhage. There is the risk of atonic hemorrhage because we may have induced that patient. It may have been a prolonged labor. The mother is exhausted. There is PPH and then atonic uterus added to pre-existing comorbidities. So it is, the nightmare has not ended. The baby is handed over to the neonatologist or the pediatrician or the anesthetist. They are trying to revive the baby. They are trying to, damage control, and yet we are not relieved. We have to be very vigilant because there can be surprises waiting for us. Rupture uterus is rare, but colporexis is very highly possible. So we have to be vigilant about, of course, atonic PPH, hemorrhage, sepsis later on, various maternal injuries, and God forbid, if we have done a ventouse or a forceps, we should thoroughly look at the cervix for cervical tears and colporexis. So it is an acute obstetric emergency. Unfortunately, we cannot totally predict, preempt, and prevent it. But the only thing what we can do here is remain vigilant, alert. We do not have any risk scores available. And remember that even estimating fetal weight, either by clinical methods or by ultrasound methods, if you can land up in misjudgment and you can still land up in a soup. We need to be vigilant. The moment you realize, you have to act. And if you have a good backup ready to step up in case of emergencies, it is definitely a boon. I would say that is in our medical training. I think it is very important, even in this age of liberal C-sections, to train each and every resident, whether it be undergrad or it can be a postgrad student, to train them in these drills of shoulder dystocia. Thank you so much for a very patient hearing, and thank you so much for this opportunity.
I now request Dr. Sanjay Gandhi sir and Dr. Parth sir to speak. Please sum up the talk and express the gratitude towards the speaker. Dr. Parth sir, Dr. Sanjay Desai sir, Sanjay Gandhi sir.
Sir Patel, sir?
Okay,
I think both the faculties are not there as far as chairpersons are concerned, but let me tell that it was the ideal teacher that we were listening to. Dr. Sushma Ben has taken such a descriptive topic of a shoulder dystocia. I must tell that after so many years, it was a complete revision. At the same time, there were some very, very important practical inputs which has been given to the new generation as far as tackling the shoulder dystocia is concerned. So it was very, very heartening and a very, very learning experience to hear Dr. Sushma Ben as a faculty. Thank you, ma'am. It was a wonderful lecture.
Thank you for your kind words, Hemant bhai.
Thank you.
પટેલ
And
સર
now,
તમને કઈ કેવું છે?
No, as far as this topic is concerned, when I allotted this topic to Sushma Ben, I was very sure that she is going to justify the topic, and she did it. So I endorse a comment of Dr. Hemant. It was complete revision of shoulder dystocia with so many inputs. We have to practice in our day-to-day practice, if at all we face this type of situation. Thank you, Sushma Ben.
So thank you so much.
Thank you, ma'am. Thank you for an elaborate talk. And we now move forward to the third talk in this academic session, that is sudden obstetric collapse by none other than Dr. M.C. Patel, sir. I request the team coroner to please share the screen. Our first chairperson for today's session is Dr. Prakash Joshi, sir. Sir is a private practitioner since last 40 years, and he has been the past president of the Himmatnagar OBGYN Society and Himmatnagar IMA. We welcome you, sir, as a chairperson for this session. Our next chairperson is Dr. Neeta Thapre, Madam, President of Ahmedabad OBGYN Society. She has been holding various posts in the Ahmedabad Society since 2021. She is the West Zone coordinator for Team Foxy and Foxy Urogyne Committee chairperson from 2017 to 19. We welcome you, ma'am, as a chairperson for this session. And our third chairperson is Dr. Vishank Patel, sir. He holds Masters in Reproductive Medicine and IVF from UK. He had All India first rank in ICOG laparoscopy course exam.
Thank you very much, Monica madam, for kind introduction.
Thank you, sir. And I request the chairpersons to please introduce Dr. Patel, sir.
Good evening all. Dr. M.C. Patel, sir. He requires no introduction. Sir was a past president of SOGOG. He was a candidate for Foxy presidential election in 2026. He will be standing for the next presidential election also. Sir has written many books. He has written Foxy Uniform Consent Rules. He is a medical legal consultant also. He has been a vice president of Foxy in 2018. Sir was chairperson in Ethics and Medical Legal Committee from 2011 to 2013. He was the organizing secretary of AICOG 2017. He is also the organizing chairperson of the VPCon 2018. He is the honorary member of the Foxy PNDT Violence Against Doctor Committee. He is also an honorable secretary of SOGOG 2022 to 2025. Sir has done a various community service also. He has been attending a camp of Dhanvantari Seva Yatra and Seva Bharti organized since 6 years. He is also the president of Lion Clubs of Gatlodia. Sir is also honorable surgeon in a Red Cross Eye Bank. He has provided services in various medical camps in Northeast under Dhanvantari Seva Yatra. Sir was the president of Ahmedabad Obstetrics and Gynec Society in 2010 and 11. Sir was also a president of Indian Medical Association Ahmedabad branch in 2007 and 2008. He is also a national president of Narendra Modi organization in 2016-2018. Sir has organized Vivekanand Enemacon as organizing chairperson. So Dr. M.C. Patel, sir, kindly proceed.
Thank you, Vishank, for kind word. Any chairperson to have opening remarks, or should I go for?
Yes, I'm Dr. Prakash.
Yes, Prakash bhai. Yes, welcome.
Good evening, Manu bhai.
Good evening.
The subject is very interesting, and sudden obstetric collapse is a condition that occurs, life-threatening condition that occurs during labor, pregnancy, and after delivery within 42 days of the postpartum period. It's an acute event involving the multi-organ systems, that is cardiorespiratory failure and all this. So every obstetrician should anticipate any obstetric collapse that happens to any patient at any time. And every patient should be granted with any kind of complications during the obstetric handling of the patient. So it's very interesting subject because it's not much credit giving to the doctor and not much result giving to the patient unless there is a efficient and effective intervention to save the life of the patient and the career of the doctor. So today we are having a long list of the panelists. So it would be very interesting that this hemorrhage, that is a PPH, APH and everything, hypoxia, pulmonary embolism and amniotic fluid embolism, then cardiovascular accidents, that acute coronary syndrome, then postpartum, peripartum cardiomyopathy, aortic dissection, though it is not common, then neurological, that's eclampsia, stroke, anesthesia complications. So it's really very interesting and very long and big subject. So I request panelists to start the discussion on the sudden obstetric collapse.
So thank you, Dr. Prakash Bhai. Let me go to the subject straight away. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies and president and secretary of respective society who have joined this webinar. Ahmedabad, Gandhinagar, Mehsana, Palanpur, Patan, and Himmatnagar. So, and again, I would like to thank you all because you stood with me just like a rock during my election campaign last year, though I lost. But I believe in this. It was written by Shraddha Atal Bihari Vajpayee, and I was lucky to work under him. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end, but new beginning, and journey to serve Foxy continued with renewed patience. So my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. And I will be seeking your blessings, help, support, and guidance next year in 2026 for the same post, President Foxy. So please endorse my candidature for President Foxy next year. Sudden obstetric collapse. Save the patient, of course, but save yourself as well. It is a very important thing because in our day-to-day obstetric practice, we take utmost care of any of our patients, but we never know. Accident may happen at any time, and suddenly we have to face very delicate condition. So as far as sudden obstetric collapse is concerned, of course it is rare, but potentially dangerous and life-threatening condition. Treatable if diagnosed and managed efficiently and in time. So start resuscitation immediately is the first motto as far as this management of any sudden obstetric collapse is concerned, and search for probable cause very quickly. So naturally hemorrhage is the very major cause and very common cause as far as sudden obstetric collapse is concerned in majority of the cases, but in few of the cases of EPH also she may go in collapse, and of course PPH. So massive obstetric hemorrhage is the matter of concern in this regard. But if there is no hemorrhage, because there are so many other conditions are there other than hemorrhage, then quickly spot diagnosis and probable causes. So which are the which could be the other probabilities as far as non-hemorrhagic shock is concerned? So eclampsia, rupture of uterus, acute uterine inversion, anesthesia's complication, Mendelssohn syndrome, acute MI and other things related to cardiac, trauma, drug reaction or overdose of drug, anaphylactic reaction, amniotic fluid embolism, ectopic pregnancy, and pulmonary embolism. So these are some conditions we should be keeping all this in mind whenever we are facing non-hemorrhagic condition and patient is in shock. So history of severe hypertension with history of convulsion, we have to think for eclampsia. History of grand multipara or previous uterine scar or instrumental delivery, we have to think for rupture of uterus. This is very quick revision as far as DD of sudden obstetric collapse is concerned, and we should be very quick enough to search all these causes. History of mismatched third stage of labor, short cord, or manual removal of placenta, that is inversion of uterus. History of fall in BP within few minutes after spinal anesthesia, supine spinal shock could be the reason. History of spinal anesthesia in higher position, difficulty in spinal anesthesia, complaint of heaviness in chest, gabramon, breathlessness within few minutes of spinal anesthesia, then we have to think for high spinal anesthesia. History of vomiting under anesthesia, problem starts within few hours, then it could be Mendelssohn syndrome. History of previous cardiac problems, complaint of acute left-sided chest pain, uneasiness, hypotension, think for maternal cardiac problem like myocardial infarction. History of vehicular accident, domiciliary violence, it could be trauma. History of collapse after administration of drug, sign and symptom of allergic reaction, it could be drug reaction or overdose of any medicine. History of painful stimuli or injection, it could be anaphylactic reaction also. History of collapse immediately after delivery, mainly in multipara or in precipitated labor, and no obvious cause is detected or any cause, then always think for amniotic fluid embolism. So these are the conditions where we should be alert. History of sudden onset of unexplained dyspnea, tachypnea, especially in Western country because of venous stasis and hypercoagulability of blood, then think for pulmonary embolism. So as far as sudden obstetric collapse is concerned, most important prerequisite for success is do not allow yourself to be collapsed. You should be very alert in this situation. Do not lose confidence. Your confidence and presence of mind will determine the outcome of patient. Do not be panic. Don't be emotional. Don't waste precious time as far as resuscitation is concerned, and you have to straightway start resuscitation. Keep labor room and OT ready to deal with any crisis always whenever you are doing obstetric practice. What to do immediately? So stepwise resuscitation we have to consider. So ABC and advanced cardiac life support is the guideline in this type of situation. Management speed makes the difference, and resuscitation protocol is same for pregnant and non-pregnant patient with fewer modification. Consider physiological changes due to pregnancy. During resuscitation, you are dealing with two patients, mother and fetus. So the best hope of fetal survival is maternal survival. And maintain the following. This is the goal of therapy as far as sudden obstetric collapse is concerned. Systolic blood pressure more than 90 mm of Hg, urine output 0.5 ml per kg per kg body weight per hour, and normal sensorium, that is normal mental status. So this is goal as far as this sudden obstetric collapse management is concerned. Eliminate the cause if possible immediately, but before that we have to resuscitate patient. And ABC protocol reminds the importance of airway, breathing, and circulation for maintenance of life. But now see, circulation is also added with compression also. Loss of control of any of these will rapidly lead to death. So all these three go in cascade. So first step is shout for help, because you are unable to manage this type of patient a single hand. So always help from shout for help, and tell your senior colleague or call them to join you for the resuscitation. Multidisciplinary team approach is secret of success. in this type of situation. So first step, assess responsiveness. So whether patient is conscious, are you okay? Like this, tap on shoulder of victim and shout, are you okay? Omit this step if patient is under anesthesia. Position, turn victim to supine position. This is particularly for roadside accident when we are going through any road, and if there is roadside accident and we have to resuscitate any patient, for this turn victim to supine position. But if patient is pregnant, then left lateral position with tilt of 15 to 20 degree will be much useful to the patient in this condition. Clear airway is the first step in treating any patient as far as collapse is concerned. So we have to search for whether airway is open or blocked very quickly. If airway is blocked, then breathing will not be possible naturally. Oxygen cannot reach lungs, and oxygen cannot be transported in blood, and it will result in hypoxia and ultimately cardiac arrest. So vital organs will be deprived of oxygen if breathing is not proper. As far as blockage of pharynx is concerned, many times due to tongue fall, some foreign body or vomiters, and we have to deal situation accordingly. So look for other signs of airway obstruction also, and with this sign we can come to know paradoxical chest movement, use of accessory muscles for breathing, tracheal deviation, noisy air entry or exit, and cyanosis. So these are the signs we can come to know. There are some other signs as far as airway obstruction is concerned. But opening of airway is very much must. It is achieved through manual movement of head by using various techniques, that is head tilt and chin lift is a very widely used method. And in this, lift the chin with one hand, push down on the forehead with other. But make sure that your fingers are not on soft spot. One more method is modified jaw thrust method. It is in spinal injury, but usually we do not practice this. Oropharyngeal airway intubation, suction, it is also one of the way to open airway entry. Once airway is clear, evaluate breathing of patient. So very quickly we have to search for that. Search for other regions for absence of breathing beside blockage of airway. Effective circulation is vital for exchange of oxygen and carbon dioxide, and cardiac arrest is mainly the ultimate cause of clinical death, and it is linked to an absence of circulation. So once airway is open, assess breathing, look, listen and feel for breath. So it is very common practice, and it is to be done very quickly within less than 10 seconds. So if breathing is there, then normal breathing rate should be between 12 to 20 per minute. And listening to external breath sound many times can reveal dysfunction. Rattling noise, that is secretion in airway, stridor, that is airway obstruction, and we have to deal with accordingly to get rid of this problem. So previous guideline was, as far as this pulse check circulation is concerned, should be assessed after breathing is assessed. But this pulse check is no longer recommended with newer guideline. No breathing, give 2 breaths is the first step, and place your mouth over victim's mouth and exhale. Pinch the nose, seal your mouth over victim's mouth, and deliver 2 effective breaths that can make chest rise. So this is the method. After 2 breaths, we have to assess whether breathing is spontaneous or not. And as far as auscultation, if we have time, then auscultation and percussion of chest to listen normal chest sound or any other abnormality. And pulse oximetry naturally will assist for oxygen concentration in the blood. If breathing is below the minimum rate, then CPR should be considered immediately with IL core protocols. And if patient is breathing, then continue with treatment indicated for an unconscious but breathing patient, that is intervention such as recovery patient and summoning an ambulance to shift patient to another center. If patient is conscious or patient is breathing, then in a conscious patient or where pulse and breathing are clearly present, then immediately look for life-threatening condition such as severe pulmonary edema or hemothorax, and we have to deal for that accordingly. Checking for general respiratory distress, you see for accessory muscle in action, abdominal breathing, position of patient, sweating, cyanosis. These are the signs to judge the situation. Checking of respiratory rate, depth of respiration, and rhythm is very much important. If any of this deviates from normal, then it indicates underlying problem. Chest deformity and movement, chest should rise and fall equally on both the sides, should be free of deformity. But if there is abnormal movement or abnormal shape, maybe in either pneumothorax or hemothorax, and we have to think for that also. As far as modification of basic life support due to pregnancy breathing is concerned, that in pregnancy, functional residual capacity is decreased, O2 demand is increased, and hypoxemia can be developed very rapidly. So always be prepared to support with oxygenation and ventilation very quickly whenever you are facing sudden obstetric collapse in any obstetric patient. Ventilation volumes need to be reduced due to elevation of mother's diaphragm. This is physiological change due to pregnancy. So with clear airway and efficient breathing, oxygen is delivered to lung. There needs circulation to be effective to deliver that oxygen to the rest of the body. So originally meaning of C was to assess circulation, but now usually, of course, it was done by carotid pulse, but now C means compression. So if it is failed to detect it, that is circulation, that in 40% of the victims, even with pulse, you may fail to detect, and in 10% of the victim without pulse, you may miss circulation. So there is less risk. It is very common dictum. There is very less risk or harm by performing chest compression on a beating heart rather than failing to perform them on a non-beating heart. Even if heart is beating and if you have performed compression, you are going to do no harm to the patient. Check the pulse immediately, check centrally and peripherally, and assess rate, regularity, strength, and equality between different pulses. But this can be done by assistant also. One person should be for compression and management of this shock. BP measurement to assist for signs and severity of shock. Auscultation of heart can be undertaken. Observation for secondary sign of circulatory failure, that is edema or frothing from mouth, that is CCF, and ECG monitoring will help naturally to rule out cardiac condition like mitral myocardial infarction. So emphasis more on chest compression is newer guideline, and effective chest compression create more blood flow through heart, and buying few minutes till defibrillation can be considered or some other helps come, we can buy time. As far as guideline of 2000 is concerned, previously it was recommended 15 compression for every 2 rescue breaths. But now with newer guideline with 2005, 30 compressions for every 2 rescue breaths are recommended. And with each chest compression in a series, coronary perfusion pressure improves and blood circulation increase with sequential compression. So ratio of chest compression to rescue breath is now 30:1. Position yourself at victim side. Victim must be lying on firm and flat surface. For male victim, remove all the clothing and expose chest, but as female patient is concerned, do not remove her last garment. Push hard, push hard, and press down 1.5 to 2 inches, and this is a real chest compression. As far as compression, then relaxation and compression, and rate should be 100 per minute, and compression ventilation ratio just I mentioned 30:2. So don't bend your elbows. This is very much important. Your elbows should be straight. Do not bend your elbows when doing chest compression. Doing so will deliver a weak and ineffective chest compression. 3 compression plus 2 breaths means 1 cycle. So one rescuer will go with 5 cycle and then change of rescuer, because naturally with 5 cycle anybody will be fatigued, and to relieve that fatigue, another person should be there to rescue the position with same regime, 3 compressions, 2 breaths, that is 1 cycle, and 5 cycles he has to go for. As far as the one study, very interesting study was there. During first and larger study, team of University of London consider 1,941 patients in cardiac arrest who needed bystanders to perform CPR. Even they were not well versed with all these gadgets, but they were simply knowing compression, and this study was taken in this sample, found no significant difference. It was inference. There was no significant difference between 981 patients who received chest compression only and 960 patients who received both procedure and mouth-to-mouth breathing. An interesting result was first group survival to hospital discharge at a rate of 12.5%, and the second had an 11% survival rate. So there was not much difference as far as this regime is concerned. So compression with tube breath is very much vital. The second Swedish study included 1,300 patients, and it is also reached with the same conclusion as far as this part is concerned. So this was conducted in July 29, 2010 and published in issue of New England Journal of Medicine. So one more interesting situation and advice is always add 1,000 before every number when you counting from 1 to 30. So whenever you are giving compression, add 1,000. Say for example, 1,001, 1,002, 1,003, because it mimics heart beating, and exactly it will mimic normal beating of the heart, and it will be much more useful to the patient. And rate just I mentioned prior also, 100 per minute with full recoil. And in a scene of an accident, always look around and check if scene is safe, as you do not want to become one of the victims. Because when many times in roadside accident, when you are going to help, but many times it happens that you may be in trouble. So be careful in this type of situation. As far as modification of basic life support related to circulation is concerned, perform chest compression higher, slightly above the center of sternum, as there is a elevation of diaphragm and abdominal content during pregnancy. As far as defibrillation is concerned, would you consider, should defibrillation be available in OT? The definitive treatment step as far as cardiac arrest is concerned, so it should be considered immediately if your compression and other parts fail. So ABCD, that is one more number F is added in protocol, and it stands for fundal height. Very quickly we have to go for gestational age, and one F is for family. Family member or witness are very important person to give us the precious information about the accident. If patient is brought to us with history of accident, or patient is brought in a collapse condition from home in a case of obstetric patient. So family members are very important persons to give us information, or may present a problem many a time to the rescuer. Fluids, to check for obvious fluid, that is bleeding for any side or CSF. So we have to look for all these fluids also, and with fluid resuscitation naturally. As far as autocaval compression is concerned, because gravid uterus is known for that, so autocaval compression is relieved with a position or so. Naturally, venous return will increase with increased cardiac output, and ventilation will improve, and functional residual capacity will be increased. So oxygenation will improve, and ultimately oxygen consumption will decrease, and CO2 production will decrease, and it will improve maternal and newborn survival. Cesarean delivery decision. Many times we have to go for this decision very quickly, but it is not easy for any gynecologist to take this decision. It is very tricky decision to take for, but has 3 to 4 minutes passed since cardiac arrest, and we have tried our all level base and still there is no result, then we can consider quick delivery as far as cesarean delivery is concerned. Has the mother responded to resuscitation? We have to consider. And was resuscitation optimum? Can it be improved? So it should be started by 4 minutes. We have time for 3 minutes for resuscitation, and after 3 minutes, if there is no result, then we can consider this and deliver baby by 5 minutes. So if the time from arrest to delivery of baby, if we can deliver baby within 5 minutes, then there could be little chance for baby also to survive. So perform operation in patient's room only. No need to ship patient to OT after in this situation. You can transfer patient only after delivery. Don't worry about sterility. Vertical abdominal incision very quickly. Prepare for uterine hypotonia and bleeding. Would you consider the need for emergency cesarean section delivery as soon as pregnant woman develops cardiac arrest? This is a very common question many times asked. And in this situation, consider the need for an emergency cesarean delivery as soon as pregnant woman develops cardiac arrest. But survival rate for infants, if it is more than 28 weeks, occur when delivery of infant occurs in less than 5 minutes after mother's heart has stopped beating, and required to begin delivery in 3 to 4 minutes as far as cardiac arrest is concerned. If gestational age is less than 20 weeks, need not to be considered as far as quick delivery is concerned, because fetal survival is nil in this type of situation, but it significantly compromise maternal cardiac output and chances of fetal survival is very nil. If gestational age approximately 20 or 24 weeks, perform to enable successful resuscitation of the mother and not for survival of delivered infant. But if pregnancy is more than 24 weeks, perform to save life of both mother and infant. With one of our gynecologists working at Riva in MP, she had quick decision taken as far as cesarean section, perimortem cesarean section is concerned, and luckily both were saved, patient as well as baby. So principle of successful CS delivery, rapid incision, rapid delivery, and rapid closure, best obtained with bold midline vertical incision is ideal for rapid delivery. Classical uterine incision, closure with large running suture in a single layer. No need to shift patient in OT, no need to scrub abdomen, no need to administer anesthesia. CS will be relatively bloodless because patient is already in shock with less cardiac output. Chest compression and ventilation should be continued. So one assistant will continue this chest compression when one person is doing a cesarean section or so. Try to resuscitate neonate and hand over to neonatologist if he is available. Placenta is removed by cord traction or by MRP. If mother is resuscitated and pulse return, then ship patient to ICU immediately and start broad spectrum antibiotic immediately. So following can increase the chances of infant's survival. Short interval between mother's arrest and infant's delivery. No sustained pre-arrest hypoxia to the mother. No sign of fetal distress before mother's cardiac arrest. Aggressive and effective resuscitation efforts for mother, and delivery is performed in a medical center with NICU backup. So as far as conclusion of this talk is concerned, so always look around and check if scene is safe when you do not want to become one of the victim when you are dealing with resuscitation in roadside accident or so. Check responsiveness, shake and shout in any of cardiac arrest. Open airway, head tilt, chin lift, modified jaw thrust. If needed, use endotracheal tube 1.5 to 1 mm smaller in internal diameter due to as compared to non-pregnant patient, because in this pregnant patient there could be edema and it will be narrow one. So narrow endotracheal tube will be much more easier to pass on. Check breathing, look, listen and feel. If breathing recovering position, manage for help, shifting for teamwork, ambulance, etc. If no breathing, give 2 effective breaths. Always assess for 10 seconds only for sign of circulation. Look for carotid pulsation. If circulation is present, continue rescue breathing. Check circulation every minute. If it is no circulation, then compress chest at the rate of 100 per minute, 30 to 2 ratio for compression to breathe. Do not bend your elbow when doing chest compression. Doing so will deliver a weak and ineffective chest compression. Perform chest compression higher slightly above the center of sternum, as there is an elevation of diaphragm and abdominal content in pregnant patient. Gravid uterus more than 22 weeks also limits the effectiveness of chest compression. Uterus may be shifted away from inferior vena cava and aorta, pulling uterus to the side. This may be accomplished manually or by placement of roll blanket or other object under right hip or lumbar area of patient. Successful resuscitation of a pregnant woman and survival of fetus require prompt and excellent CPR with some modification in technique. Defibrillation and medication dosage used for resuscitation for pregnant women are the same as those used for other adults. Rescue should be considered need for emergency cesarean delivery as soon as pregnant woman develops cardiac arrest. Rescuers should be prepared to proceed if resuscitation is not successful within 3 to 4 minutes. Best survival rate for infants, if it is more than 28 weeks, occur when delivery of infants occur in less than 5 minutes after mother's heart stop beating. So, which could be the possible outcome? Mother and babies die or brain damage. Mother and baby is intact. Mother intact, baby dies or impaired. Mother brain damage, baby intact. Family takes legal action against hospital, anesthesiologist, and obstetrician in this type of situation, because these are the potential conditions as far as litigation is concerned. How to declare bad news, involvement of rush team, death certificate, postmortem examination, involvement of police, all these are events in case of death, in spite of all your care and caution, but it requires separate session to discuss because each topic is very important. Proper counseling even after event is also very much important. Proper record keeping, whatever efforts you have put to save life of patient should be well documented because it will be required in court of law. So there is always a way. So if you want to sleep like this, take tender care of your patient and be fast as far as resuscitation part is concerned. In any of obstetric collapse is concerned, pray your Almighty God before going to sleep and keep my visiting card below your pillow. With regards, salute to all. And again, it is my humble appeal to endorse my candidature for post of President Foxy election year 2026. Thank you very much. Please do not assume. Please ask any query, any question if time and chairpersons permit. Thank you very much.
Thank you, Manubhai, for giving great information about the very crucial subject. It's a nightmare for both the doctor and the patient and the family, but the ABCDEF is very important. Resuscitation is very important, and all the steps we should be consider all the things well equipped in the labor room as well in the OT. OT should be equally equipped with all the gadgets on hand in active condition. We should have always checkup of all the things every week in labor room and operation theater. Sometime at the time of emergency, some instruments are malfunctioning. So even if you are having defibrillator, you should have a testing every 15 days, right? And another thing is always keep your anesthetist ready while you are doing all the things. Ask the colleague, because though it's a matter of 2-3 minutes, but we should have somebody who is coming and on the way. And when we are busy with the resuscitation of the mother, the other medical associates will help to prevent further litigation in our setup. So thank you, Manu bhai. Thank you so much.
So it is very rightly said that if you involve any of your colleague, it shows your consent to save life of patient. And in court of law, whenever you are facing, in all the cases, ultimate result is not taken into consideration, but your efforts to save life of patient is also taken into consideration. So if you have involved your professional colleague, whether they are gynecologists or anesthesiologists, and if you have put all the efforts to save life of patient, and if you can convince court with your proper documentation, then in many of the cases, it has come in favor of doctors also.
Thank you.
Yes, Monica, we can switch over to another session.
Sir, may I ask something?
Oh, yes.
Sir, you mentioned that during accident, look after your own safety also. So what exactly were you trying to say?
I mean, exactly in this type of situation, many a times it is not possible to revive patient in few of the condition. Then a crowd may take it another way, and there could be assault on yourself also. So you should be very
We should be judicious.
vigilant. Yes, vigilant.
Yeah, just no below humanitarian ground. Sathe we have to think of something else. So
Yes, yes, our safety.
thank you, sir.
Yes.
I think we can move ahead, sir.
Oh, yes. Oh, yes.
Yeah. Thank you. Thank you, MC, for once again enlightening us with that nice talk. Thank you, Prakash, sir. After those three very nice talks, we will move on to the panel discussion. We have a very interesting panel discussion coming up. It's on case scenarios in labor room emergencies. We have two eminent personalities as our moderators, Dr. Parul Sarfaraz Kazi. Dr. Parul Kodrawala sir has been the chairperson of ICOG. He is an endoscopic surgeon and gynecologist at Zydus Hospital, Ahmedabad, as well as the professor and head of Sai Institute of Medical Sciences, Ahmedabad. Has been the vice president of ISOPAR 2021-22. Welcome, Parul sir. Our next moderator is Dr. Sarfaraz. Dr. Sarfaraz is an onco-gynecologist. He is the director of Navjeevan Women's Hospital at Himmatnagar. He is also a consultant gynecologist, endoscopy and infertility specialist practicing in Himmatnagar for the past 20 years. Welcome, Sarfaraz, sir. Our expert for the day is Dr. Jignesh Deriwala, sir. Sir is a consultant at Geeta. Yes. Sir is a consultant at Geeta Maternity and Nursing Home and 3D, 4D sonography and laparoscopy center at Ahmedabad. Sir has been trained in the Ian Donald Diploma in Obs-Gynae as well as trained at Mediscan for fetal echo and color Doppler in obstetrics. His special interest lies in high-risk pregnancy. So I think his contributions will be of immense help today. We have a very interesting group of panelists with us today. Our first panelist is Dr. Ishan Shah. Dr. Ishan is a consultant at Ma Uma Multi-Speciality Hospital, Unjha, as well as a senior consultant at GMERS Medical College, Vadnagar, and joint secretary of the Mehsana Obs-Gynae Society. Welcome, Dr. Ishan. Next panelist is Dr. Khemraj Chaudhary. Dr. Khemraj is a consultant at Chaudhary Hospital at Tharad. He has been practicing as a private gynecologist since the past 16 years. His special interest is obstetrics and infertility. Has served as the president of the IMA Tharad branch. Welcome, sir. Our next panelist is Dr. Anand Chaudhary. Dr. Anand Chaudhary.
Yes.
One second. Hello. Yeah. Dr. Anand Chaudhary has a gold medal in Gynae in 2004. He is the director of Upavan Multi-Speciality Hospital at Palanpur. He has been working as a private practitioner at Upavan Hospital and IVF Center. Welcome, sir. Our next panelist is can I have the next CV, please? Next panelist is Dr. Chirag Joshi. Dr. Chirag Joshi has been practicing as a gynecologist at Ukti Maternity Home at Gandhinagar and is a strong believer in parenthood dream. He also has been practicing since 2001 and has an ultrasound in obstetrics and gynecology from the Endol Association. Welcome, sir. Our next panelist is Dr. Naisargi Patel, ma'am. Ma'am has a diploma in aesthetic and functional gynecology, as well as is a certified practitioner and counselor in sexual medicine, as well as the member of IASMP. And she practices at Gayatri Maternity and Nursing Home at Patan. Welcome, ma'am. Our next panelist is Dr. Viral Luhar. Sir is a gynecologist, senior gynecologist at Gandhinagar. Welcome, sir. Our next panelist is Dr. Mahendra Soni, sir. Dr. Mahendra Soni, sir, has been the president of SOGOG in 1995 and 2024. He is the founding president of Himmatnagar Obsgynae Society, that is in 1994, and has been practicing at Himmatnagar since then. Welcome, sir. So over to you, Parul sir and Sarfaraz sir. Oh, we have one more panelist, Dr. Paresh. Dr. Paresh Solanki is a laparoscopic surgeon. He has the achievement of doing more than 8,000 laparoscopic surgeries, and he is the director at Galaxy Laparoscopic Hospital at Palanpur since 2024. Welcome, Paresh sir. Over to you, Sarfaraz sir and Parul sir, for the panel discussion.
Well, thank you very much, Dr. MC, for asking both of us, Sarfaraz and me, to conduct this panel. Labor room emergencies are always tricky situation, and everyone knows everything. And yet, how to deal with the situation is the trick. And that is what we expect, because I have observed that all the panelists are practitioners with lots of experience, and they are all in sub-district level or maximum at district level. So they have attended real difficult situations. We in a bigger city have recourse to medical college hospital where we can shift the patient. These people have a tougher task on hand, and Sarfaraz is also one of them. And I'm very sure that the discussion following will be very useful to all of us. Sarfaraz, you can start with the presentation.
Yes, sir. First of all, thank you very much, Dr. MC Patel, sir, and the whole team of Happy Learning Masterclass webinar series for inviting all of us for this wonderful webinar. Thank you, Monica, both the Monicas, Nivedita and Deepika, for conducting the wonderful webinar series for MC Patel, sir. I have already sent the slide, so I asked them to share from their side only. Yeah. So day by day, as Parul sir is telling that whatever we are doing in our today's practice, whether we are becoming the IVF specialist or becoming a laparoscopic surgeon, but we are basically hardcore obstetricians. And we all go through all these labor room emergencies, starting from PPS, placenta previa, eclampsia, rupture uterus, inversion, cord prolapse, shoulder dystocia, very well described by the previous speakers, DIC, amniotic fluid embolism, chorioamnionitis, septic shock, and so on and so on. We are now going to discuss the practical issues which normally we encounter in our labor room, and this discussion will become the bridge between the periphery system of the labor room management and the higher center system of the labor room management. Next. So whoever is the panelist can answer the question. This is case one registered second gravida para 1 with 9-month amenorrhea, came with strong labor pain. Her vitals were normal, uterus full term, contraction moderate, counter well maintained, head is fixed, FSS is normal. Patient started bearing down and spontaneous rupture of membranes occur with fresh gush of bleeding with sudden drop in the fetal heart rate. So any of the panelists can answer the first question. What is the diagnosis?
Maybe uterine rupture.
Okay, second option.
There may maybe the abruptio placenta.
Abruption. Abruption.
Okay. Third option.
But the contraction is there, so abruption may be ruled out.
You can go through the slide and rule out other differential diagnoses. Contour is well maintained.
Yeah.
Okay. So chances of rupture is also, you can say,
Ruled out.
very less. Okay.
Yeah. Mm.
The fifth point, patient started bearing down. There is a spontaneous rupture of membrane. And when membrane got ruptured, there is a fresh gush of bleeding with sudden drop in fetal heart rate. Jignesh Deriwala sir is there, our expert?
Quad prolapse maybe.
There is a bleeding, there is no cord.
Okay.
It is related to cord, but if there is no bleeding, there is no cord, there is only bleeding with gush of liquor coming out.
Cervical tear.
No.
Any abnormality in vessel, vasa previa also?
Yes, definitely so. Next.
Vasa previa.
So
Vasa
this is a
previa,
this is a clear-cut case of vasa previa. The only thing we found in the case of vasa previa is there is a sudden bleeding. Bleeding will come suddenly after the rupture of membrane. Next.
Yes.
So this is the situation in the vasa previa with filamentous umbilical cord insertion or vasa previa with multi-lobed placenta. I have encountered one multi-lobed placenta with vasa previa recently. Last week, I was just worried about the one placenta was a little bit placenta previa, but it was shifted and there is a filamentous insertion with there is a vasa previa in between the two placental insertions. So this is the situation in the vasa previa. We are encountering this type of cases in periphery, very less in the incidence, but it is there. Next. So in the cases of vasa previa, umbilical vessels separate in the membranes at a distance from the placental margin, and some of the vessels cross the internal os and occupy a position ahead of the presenting part of the fetus, and this is the reason why there is a gush of bleeding after rupture of the membrane. Next. Diagnosis: moderate vaginal bleeding with fetal distress. Vessels may be palpable through dilated cervix. If you are very accurate, vessels may be visible on ultrasound. Previous ultrasound report, if showing it like this, we have to be careful. Difficult to distinguish clinically from abruption. Can look for fetal HB or nucleated RBC in shed blood for the diagnosis. And there is a risk for the fetus also. Next. So differential diagnosis, as you all have suggested, all three, early recognition and rushed cesarean section as soon as it happens has been associated with 60% fetal and neonatal mortality, even if we go for the rushed cesarean section. Only way is to have high index of suspicion, perfect diagnosis prior to the delivery by ultrasound, early recognition of dark red blood after spontaneous or artificial rupture of membrane, preferably antenatal diagnosis helps us a lot. It can be diagnosed antenatally by ultrasound color Doppler, and antenatal diagnosis, if already is there, plant CS is the only effective way to make the baby survive. Sir, Parul sir.
So just a second before continuing the second case, we have encountered similar type of scenario in a labor room in a medical college, but with the same history, but the only fetal heart rate was found 180, 190 in a emergency situation. So what kind of is there associated with vasa previa or not?
It can be associated with vasa previa.
But rest all the history was same. Only fetal heart rate was found suddenly
That
aggressively
tachycardia,
increasing. Yeah.
that tachycardia will suddenly go to the bradycardia within a fraction of minute.
Ultimately, what happened in that case? You received that patient. What happened?
With similar history, patient was in labor, spontaneous rupture of membrane, and within a minute, the fetal tachycardia 180, 190 was found. informed to respective faculties and was immediately shifted to for emergency cesarean section.
Membrane was
Baby
rupture or not at that time?
ruptured. After rupture of the
So,
spontaneous rupture of membrane.
so
There is a
after
bleeding.
cesarean, what was found in placenta?
Placent the vasa previa type of situation was found but not confirmedly diagnosed.
Okay,
Then,
there is a no
then we
retroplacental
can't say
clot or
anything.
something.
No, we couldn't differentiate for abruptio because not confirming the abruptio with the diagnosis after cesarean section. But the fetal distress was confirmed. Baby was in NICU for a week, and then mother and baby was safely discharged.
What
And
was
there was
the
a bleeding.
released hemoglobin? Any idea?
Hemoglobin was before labor antenatally was 11
No,
between
no, no,
10
not
to
the mother. I'm talking of the baby because here the baby bleeds.
yeah.
So
But
there would be
Yes.
reduction of hemoglobin in
fetal
fetal.
anemia.
So could you find that or that was not checked?
Not checked, sir.
No, it would.
So
If the baby was in NICU, it would have been checked. Maybe you
Yeah,
just don't know
definitely.
about it.
Hmm.
but had it been very abnormal, it would have been registered. I mean,
Yes.
everyone
Any
would be aware of that if there is a big change. So
any
Yeah.
NICU patient, they are doing the hematocrits and everything. Yeah,
Yeah,
so
Yeah, but
hmm.
I will check because it was a very recent case, so I will definitely check with the NICU.
So check
Hmm.
that. But see, this is what we have to do. We have to put a diagnosis as far as possible. Many times we just do not reach at a diagnosis and then we may not learn from that experience. So try
Yes,
and
sir.
reach for a diagnosis as far as possible. You may have to stretch yourself a little bit,
Yes,
but
sir.
try and do that.
Yes, sir.
Could you take a look at the placenta?
That is what he said, that they were not
Yes.
sure it was with
Not
vasa previa or not.
Because sir, vasa previa usually on actual visualization of placenta can be seen. Ultrasound may be difficult, but direct visualization though possible.
Generally,
Hai.
you should be able to confirm that.
yeah. Yes, sir.
Hmm.
Next case, Parul sir.
Delhi છે our
ના
expert.
નથી
Okay.
જિગ્નેશ સર નથી.
Okay, you can continue, Sarfraz.
Okay, sir. Case
See,
number
let
2.
me share with you the entire effort is by Sarfraz. He has developed these slides,
Correct.
and I'm very thankful to him for that.
And with the guidance of sir, we make all the cases interesting to discuss, which encounter in our day-to-day practice. Case number 2, 28-year-old second gravida delivers a baby of 3.8 kg by vacuum after trial of 12 hours. After 30 minutes, staff informed that there is excessive bleeding and with passage of clot, patient become restless, paler, pulse 120, BP 90/60, respiratory rate 24 per minute. We are going to discuss this as a whole, as a routine labor room
As a case
emergency.
of PPH, I
Yeah,
think.
it's a clear case of traumatic PPH maybe.
It's
No,
acute
now
primary PPH leading to hypovolemic shock because of uterine atonic and because of prolonged labor, and that leads to uterine exhaustions and because of instrumental delivery. So,
May I interject? 12 hours is not a very prolonged labor, right?
yes. So you can keep one by one scenario like what are the possibilities and how will you manage? Suppose what will you do immediately? You were in
It's a
your
case
consulting
of
room. Yes, Ishan.
hypovolemic shock. So first, the circulation, examining the patient, infusion of IV fluids, IV cannula. The hypovolemic shock should be first corrected, and then find out whether the cause of bleeding, whether it is a traumatic PPH or atonic PPH.
So you alone will go to the labor room and do all these things.
No. Definitely the team will be
Yes.
required. We need to
Yes.
call
Yes.
for the help. Everything
Yes.
need to be there.
And blood products should be requested at
We
As
call
early
for
as possible.
senior obstetrician, anesthetist, and pediatrician nurses, rapid assessment for airway, breathing, circulation. Then we'll put patient on flat and keep warm. And both IV line with 18 gauge or 16 gauge needle. And
yes.
we'll draw blood. We'll send for all blood investigations. We arrange crystalloids. Then we'll arrange platelets and other blood products. And we'll maintain urine output more than 30 milliliter per hour. Then we'll rule out causes and uterine atony, trauma, or tissue thrombin.
Very good. Next. So the PPH is encountered almost 10 to 50, 20% of 10 to 20 per 100. And next, why it is a concern? Because each year about 14 million of women experience PPH, resulting in about 70,000 maternal deaths. I am not going to the literature. Next. Important thing is failure to recognize excessive blood loss and estimate amount of the blood loss, because sometimes trickling is coming. We are not looking and we are not measuring how much blood loss is there. And once there is a patient becomes paler, tachycardia, hypotension, then we understood that this is a severe hemorrhage. So we must have our staff aware that how to measure the amount of the blood loss. Another thing is we are reacting very late. But in the cases of PPH, we have to act precisely with our team, and we at our center, at least we should have 3 to 4 staff who have been given a responsibility. We have to do the drills occasionally, so they are get prepared. Means in our labor room setup, if there is a case of PPH or any emergency, every staff is ready for their work. Like one is taking another intracate, one is calling to anesthetic, one is doing this, one is taking blood for the cross match. Everybody is doing simultaneous work. Then and then only we can manage any emergency. Next. So how to estimate the blood loss, we all know very well. Next. So our priority should be to stop the bleeding. We will expose the whole vulva, cervix, vagina. First, we will make confirm. After putting the hand on the abdomen, we will come to know whether it is atonic or traumatic. If uterus is very well contracted and still there is a bleeding from the vagina, we will explore the vagina. For that, we may need the help of the anesthetic. And then if we found any tear, either vaginal tear or cervical tear or fornical tear, we will do the suturing, preferably under the anesthesia. So if there is a posterior fornix tear and it is extending up to the angle of the vagina, so how will you manage? Anyone? We are not going to the theories. We are going to the practical approaches, what we are doing at our places.
Suturing is ideal, but we should keep in mind that rectum should not be involved during the tissue bite.
Yeah, very good. So for that, what precautions you will take?
You can do per rectal examination simultaneously, or your assistant can do per rectal
Yes.
examination.
Yes, if you are worried that the tear is very deep, you can ask your assistants to put the finger inside the anal canal, and then with the guidance, you can start to take the sutures. What else important thing you will keep in your mind? If the fornicial tear is connected with the, just forget about this case. If the fornicial tear is connected with the angle of the vagina, angle of the episiotomy, so from where will you start?
From cervical part only.
This is a fornicial tear.
Yeah.
You should go bidirectional.
Basically, I feel that you should just look at the blood from where it is coming. Is it from the
Yes.
edges of the tear or is it deeper down? Because you just keep looking at it. If it is deeper down, what you will suture will just cover that. And inside the blood will get collected and will keep on dissecting the peritoneum and going upwards. So I would prefer, if edges are not bleeding, to just pack the vagina for some time and watch the recovery of the patient. If patient recovers, then you can suture later on after say hour or two. But at this point of time, just packing the vagina would be the right thing if there is no active bleeding. Because that will tell you if the bleeding is deeper, then patient will continue to get lower down. And you can then ask for an ultrasound also to identify a clot which is growing deeper inside. I have attended many emergencies where outside the vault is sutured and the blood gets collected on the inside.
Yes, many of the times what happens, I didn't have that picture in this PPT, but I am trying to show you if you can see and you can recognize this. If this type of tear, you can see
Yeah,
this is
but
this is the epigeo. This is the epigeo. This is vaginal mucosa. This is the angle, and this is the vaginal tear. Okay, this case we have handled many years back. What happened? All things has been sutured, but still there is a hematoma above the epigeo angle. So one consultant has reopened all the things, drained all the hematoma. They didn't found anything. Again, they resuture. After 4 to 5 hours, again there is a hematoma. So finally, the diagnosis came. We cut the angle more from the apex because the vessel which was bleeding was retracted.
Retracted there. Cervical, maybe
Retracted, yeah,
branch of
retracted above the level of the angle.
And then
So the ideal thing in this case is you have to take your first suture at least half centimeter above the angle, so that any of the retracted vessels will be tied at that time.
likewise in cervical tear.
Same. Okay.
But see, the bleeder can be 1 inch away also. So at that point of time, just pack and watch. If patient is recovering, fine. Then you can suture it after 1 hour or so. But if patient is not recovering, declining, then you have to do an ultrasound whether there is a deeper bleeding or not.
Yes, sir.
Okay, next slide.
So traumatic is generally, you can say 10% of all PPH, but atonic is 90% of PPH.
So in the same case, if we will discuss that, if there is a no tear, no hematoma, cervix is not bleeding, but uterus is atonic. So what will be the plan of management?
Definitely, treatment plan goes with the medical management, and definitely we will give this inotropic supports everything. This IV fluids and if needed, blood will be there. And I will prefer to do packing.
Which uterotonics generally people are using, and
oxytocin, methadone, prostaglandin.
up to what level that Parul sir will tell afterwards. But routinely, what we are using is
we give methadone IV, oxytocin 4 unit in drip, and drip goes that we have to set drips, but we roughly it goes very fast.
Methadone is given to, so let's see, 2 ampule IV, oxytocin 20 units is running. Still, uterus is atonic.
We give prostaglandin also.
Prostaglandin.
We also use mesoprost per
simultaneously anything we can do apart from
bimanual compression Bimanual
Yes.
compression.
Massage.
So one person should be there who is doing continuous bimanual compression.
Bimanual compression, yeah.
Yes, that will
Bimanual
give a very
compression.
good effect because any medicine will take time to get effect. So till then, if we will continue the mechanical bimanual compression of the uterus, we will get better result. Sir, Parul sir, you can add something.
Okay, 2, 3
Anybody?
things. Yes, anyone would like to add on to this?
We can give
balloon components, sir. Condom catheter balloon we can add. We can.
How many people? How many people are using either balloon tamponade or condom catheter or that suction cannula? Anyone?
Not routinely.
No, no.
No.
Using
Any
means
experience of these things?
yes. Particularly,
Yes.
I'm asking.
So please share your experience.
I am very happy with packing.
We want to know your experience because so
packing-
many things has been in the conference. We came to know that this is the new innovation. This is the balloon catheter. This is a suction vacuum cannula. So if you people among us, if you are having any particular experience for any this mechanical device to control the atonic PPH.
I am using packing only, and I am happy with that.
I am also using the packing thing, and it gives very good result.
So pack is by what? Gauze piece or by balloon or?
I do packing with mop.
Mop.
That
Okay.
vaginal
Sterile mop.
sterile mop, definitely autoclaved.
Mhm.
And tight uterus packing is sufficient for most of the patients. And these decisions are mostly taken in time. We are not waiting for patient to allow to bleed a lot. So fast decision makes a difference. And definitely uterotonics and everything goes simultaneously. Even in very bad conditions, we can keep pressing aorta also by one hand on the aorta. That will also help. These things can be done. We have Bakari balloon, but instead of Bakari balloons, it is routinely easily available. Now we have started keeping this Bakari's balloon for easy use also. Recently, we have used one Bakari balloon in one of the patient in CS. So it's okay. We are happy with that also.
Parul sir, your personal experience with any?
I have used so many things, but first thing which I think we have missed out is tranexamic acid.
Yes.
Now, it is a guideline that always give 2 gram of 1 gram, and it can be repeated once again. So total 2 gram maximum IV tranexamic acid. That will reduce the amount of blood loss. It will not stop the bleeding. Then we come to the mechanical measures. So when you want bimanual compression, people are afraid, but you have to put your fist in the vagina that much, and then you lift the cervix, and abdominal hand flexes the uterus over that. So the fundus is below the cervix. That kind of flexion has to be done. 2 finger in anterior fornix will not produce your bimanual compression. So, and once the baby has recently delivered, you'll be able to pass your fist. Lift the cervix, that will angulate the uterines, and then compress the fundus over that fist. That would be effective. Regarding balloons, see, previously we were all packing, and the balloons have a smoother surface. That is the benefit. But they are fixed stretching. What we want is a dynamic balloon. That means that once the uterine contraction starts, it should not remain that stretched. The uterus should be allowed to reduce in size. And so now we have dynamic balloons which are attached to a bottle. So you can reduce the pressure inside the uterus once you observe that bleeding has stopped for say 1 hour. Then you reduce the pressure inside. Let the uterine contractions also work. Otherwise, fixed distension balloon or packing, we remove the pack after 8-10 hours. So when you remove, the uterus remains flabby because it has remained stretched so long. So you can look up, there are many such balloons designed where you can gradually reduce the amount of stretching, but yet the pressure remains same. The uterus keeps contracting, so pressure inside is generated. Suction cannula is also an option, but that is to be used only in presence of some uterine contraction. If there are no contractions, then suction cannula will not work. You can always try it, but generally uterine activity has to be there, so it contracts over the suction cannula. Otherwise, it will not be effective. So one is stretching, one is reducing the size inside. You will have to choose judiciously. I have used condoms also for distension, packs also. All of them by and large work equally well. Nothing can be considered superior to other. In a given situation, something works and I would feel this is the best. But we all have very little experience. We do not have such a wide experience that I can say 50 cases of balloon versus 50 cases of pack versus 50 cases of suction, which is not possible unless it is in a big medical college where over 3 or 4 years you gather this kind of data.
In
But yes,
South India, I have heard, I am not experienced, I have heard that they are providing these Bakri balloons and the suction cannula to the lower centers, government setup. So just to accommodate the uterine contraction or to stop the bleeding until the patient is going to get shifted to the higher center.
See, especially Tamil Nadu and Kerala, they have perhaps the best data as far as maternal survival is concerned, or reduced maternal mortality in our country. Karnataka is also doing very well. So their government is very proactive. And so the government is giving this for their PHCs. They have also trained their MBBS doctors quite a lot in PHC level to take care of PPH and maternal mortality. So that is there, but we can also do it. There is no cost involved. In fact, the doctors need to be conscious about it. Suction cannula, how much does it cost? Or balloons, how much do they cost? Now, of course, Bakri balloon was slightly costlier, but the government of India, Madhya Pradesh government, and I think it is Raipur near Chhattisgarh, they have developed a balloon which is locally made and the cost is very low. And I think the company which is marketing many things about family planning, they are also selling this balloon. Cost is around 2,000 rupees, whereas Bakri is around 6,000.
Yes, sir.
So that can be also used. Even condom can be used properly if it is used. You put your Follis catheter inside, inflate the balloon of Follis catheter and tie your condom below that. Place it inside the uterus and start inflating through the catheter 1 to 1.5 liter, and till the time you can keep the bottle, so you do not keep fixed pressure. Keep an open saline bottle. You cut the top of the saline bottle, 1 liter solution inside, and it goes into the uterus. When it stops going, that is the time to keep it at about 1 meter height. Then when the uterus will contract, the water will come back. So some of the water will overflow. That is the time you know that you need to reduce the pressure. So remove some more water, keep it at that level. Gradually you keep on bringing it down. Once it is just 6 inches above the body, then you can remove that balloon. This is a dynamic kind of a balloon.
Practically tedious, sir.
Sorry?
Practically tedious લાગે છે, પણ definitely તમે જે કહો છો એ પ્રમાણે it has to. The packing was excellent, good idea, but this dynamic balloon I heard for first time from you, sir. So this is definitely a good idea, and definitely principle works like that only.
It's very simple. It's not very complicated. Only thing is, maybe you can see it once and you can start doing it. And I must say, the credit goes to Dr. I forget his name. He's from Mumbai. Very self-effacing person. Very simple. Nobody even knows his name. He was in Grant Medical College, professor, full-time professor. He has retired now. He, for the first time, gave this idea. Subsequently, there is one Zhukovsky balloon, which is from Russia. Principle is same. Only thing is the device is very fancy and decent looking. This looks
Yes.
very crude, but otherwise the basic idea remains same.
Yes.
Sir,
Can I
can I
add
say something?
something here?
Yeah, please.
As Kaji sir told, like in South, they are using this cannula and balloon. Actually, they have one Emocal system. In that labor room, sister and doctors they are training, and they'll take pre and post test. And after that, if you are clear the test, only then you can work in a labor room. So, and they'll give protocol for whole Kerala and like that. So they have printed Kerala protocol that we have to put in labor room. So if doctor is not available in emergency, sister can read that protocol and they can treat primary to patient. So PPH kit is different, they'll made, and all PPH and PIH protocol are available in their labor room. They'll keep that protocol.
Yes,
That
Naisargi,
is a good idea, but we
there are
all can do it at our level also, like
yes,
a
there are
medical college, labor.
universal protocol.
They can put up a protocol. Sushma is
Yes.
there. They can have it in their VS hospital also, NHL
So,
or.
yeah, we have our SOPs as we call it, but they are all based on the Foxy thing. We have our
Yes.
Foxy training also, the PPH drills and everything.
So
I just
Sushma,
wanted
all
to
your
add one thing.
nurses and other staff would be able to do it.
No, sir, because we have a little bit of administrative thing. We do not have dedicated LR nurses. They are
That is the
rotating in duties and all that. But at least all residents and are trained. And we have a decent staff related to residents. એટલે બધું manageable થઈ જાય. But there's just one thing I wanted to add is whenever you're in a periphery and in a lower resource setting, whenever you PPH and fall in blood pressure, immediately put the patient on a flat bed and elevate the legs. So immediately you have the reserved blood from the peripheral pooling
Lower limbs.
into the circulation, and this will really help the patient to maintain perfusion.
You will buy
That
some
is
time.
one thing. Yes, it will buy you a few minutes, not a lot, but still it is very useful. Sudden collapse માં બહુ કામમાં આવે છે. And second thing is, like we mentioned, they are also using pressure garments.
Yes.
Yes. Non-shock
Especially
garments.
Rajasthan,
Shock garments.
Karnataka, even Kerala, I believe. They have pressure garments given to all the smaller centers. And like you said, specifically for transport. And the team is very well versed with the pressure garment, and that reduces mortality to a great extent. Even morbidity burn significantly reduced થાય છે એના લીધે.
This is the only thing we are lacking in Gujarat, anti-shock garments. We have already discussed in last our maternal mortality meeting with the collector that this issue should be kept in mind, and all the peripheral centers where now all the PSCs they are having some MOs and they are conducting the deliveries and they are referring the patients in a condition, moribund conditions. So this thing government should take on its account. We have already requested for at least these anti-shock garments should be there at each and every place where government is allowing
Center.
medical
Yes.
availability. Yes.
And
Surprise.
it
Yes.
comes with a
Foxy.
patient, and then it is sent back. And sir, Foxy, I think Rajasthan mein Foxy, some other NGO and their government, they all have come together to provide these pressure garments to all small centers.
Bro, pressure garments were offered to all gynec societies by Foxy through FIGO via Foxy. Those who wrote to them, they got it. Unfortunately, Gujarat societies did not write to Foxy. They were giving it to the societies, not to the college or government. But I think no society in Gujarat asked for it.
Because the garment is expensive, I think 1.5 lakh કેવા કંઈકનું
No,
છે.
no, no.
No, no,
It's
no,
not
no, no,
that
no, no,
expensive.
no, 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 no.
9,000. 8,000 to 9,000. That's it.
It's
Just
not
that?
expensive. In fact, all private
8,000 to
practitioners can
9,000.
also have it.
Oh, sorry.
8,000.
Yes.
Yeah.
But
1.5 lakh તો પેલું મામા ને ટાલી છે. Sorry.
I would like to mention one thing. Under Safe Motherhood Committee Foxy, when Preeti Kumar was chairperson and Nivedita is here, she was instrumental to train our paramedical staff in case of PPH, how to deal with a patient till further good help is available. So Nivedita, you can share your experience.
Now, I would here add something. We have SOGO conference on 19, 20, 21st December. And on 19th, the workshop on obstetrics, we have dedicated 2 hours for this. The models are there and how to handle PPH will be handled by Dr. What is her name? She is the chairman, ICOG chairman elect, Sheila Mane.
Sheila Mane.
She will be conducting that training for anyone who is interested. And I request all of our colleagues, junior colleagues, to take benefit of that.
Nivedita, can you share your experience? You were training paramedical staff as far as the management of PPH in periphery with limited resources are concerned.
Yeah, it was really a very wonderful experience because every paramedic was trained hands-on on the UBT as well as NASG and with a proper referral system. So initially it does but the problem is that people then stop. Unfortunately, in our country, they'll use it once, they'll use it twice, and then it is relegated to some store because of some bureaucratic red tapeism. So that goes inside a store under lock and key. And when you next time you require it for transportation, they'll say कि हम तो नहीं देने वाले अपना NSD. So that those are the issues which occur with the transportation problem with NSD. But we were training all the obstetric care providers, especially the paramedics, as well as in the PHCs and the CHCs, the medical officers as well as the paramedics about the PPH, the E-motive as well as the FIGO bundle approach. That is what Dr.
The time has come that we may train, but we need to check at the results. Has it really made an impact in reducing the maternal mortality? Because otherwise, all this becomes a sort of lip service. Anyway,
Absolutely.
Dr. MC, how long are we supposed to continue this discussion? Because I see the watch, it is 8:30 plus.
Well, you can complete this or at least one case, that's all.
Okay, Sarfraz, accordingly. Anyone would like to add on to this? Because PPH by itself can take hours for discussion.
Yeah,
If this case is over, then you can have one more case, or you can continue with this case and conclude the session.
I understand. So we will not go into the surgical part of all this, just the
Yes.
medical part. We have discussed mechanical aspects as well as the medicines. Medicines, tranexamic acid first, oxytocin for prevention as well as therapy. For prevention, it is 10 units. This is for vaginal birth. And for PPH, you can go up to even 50, 60 units of oxytocin. Fast IV can be given, but you have to keep in mind that it can lead to water retention. Then methergine injections are good, but they have to be kept in refrigeration. Otherwise, the efficacy is lost. Carbetocin, some of you might be using for prevention, but vaginal birth, by and large, it is not yet approved. It is approved for cesarean section. Then prostaglandin. Rectal prostaglandin is good for prevention, but not for therapy. And injectable prostaglandin, yes, they can be very effective and can be repeated up to 5 to 6 injections every couple of hours. You can't give all at a time. Otherwise, side effects will crop up. Other than that, anyone would like to add anything?
I would like to add one thing. If we are
Please.
going for the packing, normal mop packing will not work. Proper roller packing should be there, very tight. As our one of the panelists, Dr. Soni sir is not there. He has developed a pagdi pack. It is as big as the pagdi, and we all are keeping one pagdi pack at our place in for an emergency. It is made up of the roller gauze. It is very much long, few meters long, This only will work for the proper compression. Only mop packing or only pad packing, I think it will not work in a pure case of the atonic PPH. We will move for another case. We are going to move the slide as fast as possible. Please, Nilesh.
Just a moment. I would like to
Yeah, yeah.
add, Parul sir, you said we can also use fibrinogen, though it is
Next.
very expensive and it is probably not available everywhere, but just to complete the list,
Nilesh, you continue to move
fibrinogen
the
can be
slides.
used. Yes.
Next. You continue, ma'am. I'm just moving the slides.
No, that's just it. I was just saying that fibrinogen is now another drug available to us
Stop.
in our armamentarium. That is it.
This one slide I just want to show regarding the sections of the blood supply of the different part of the uterus and cervix and the vagina. Because if there is a hematoma above the level of the levator ani muscle at that region, no packing or nothing will be helpful per vaginally. You have to either open the abdomen or laparoscopically. You have to ligate the internal iliac to come out of the any hematoma which is supralevator. Anyone else want to add on this? Move
Agree.
on. Next slide. This is the case of that
Hematoma.
supralevator hematoma. Next. Next. Next.
Could
Next.
we go back? Could we see that hematoma slide again?
Yeah, please.
Is this supra or infra?
No. This was last one picture. You can say this was a case which has been discussed. First one is from the book.
હું જરા
First one
નીકળું
is
છું. પેશન્ટને ફૂલ ડાયલેટેશન છે. Let me go for the delivery.
okay.
I'm sorry to leave in the middle. Please continue with the discussion.
Okay.
Thank you, Parul.
Yes. Thank you and best luck, Dr.
Thank you, sir. Thank you, sir. This is the picture of all type of hematomas. I am just referring last picture. Last picture was referred from the Rajasthan with this type of picture. Patient was delivered before 12 hours. They have tied everything. They have sutured 2 times episiotomy in fear of the hematoma. Just look at the last picture. And there was a multiple vaginal lacerations because delivery has been done by the Dayan. You can see na, that midwife, not a midwife.
Die.
Okay, the patient,
Yeah.
that Dayan shifted the patient to the private clinic. They shifted to the another private clinic. They have 2 times reopened the episiotomy. Still there is a bleeding, and though little bit bleeding was stopped, the patient was not that much in shock. The patient was going to the Ahmedabad Civil Hospital midway at Himmatnagar. The ambulance people know me. They came to me, and without touching or doing anything, I have diagnosed that there is a in USG there is a big broad ligament hematoma.
Okay.
In that case, we didn't touch anything per vaginally. We do the interiliac ligation. The hematoma was resolved on its own. Next. Next case. Okay. Mrs. XYZ, 34 weeks, presented in labor for 6 to 8 hours with rupture of membranes en route, Gravida 6, Para 5, Live 2, high floating fetal head on abdominal examination, fetal heart at 92, per vagina 8 to 9 centimeter dilatation, membranes absent, presenting part not palpable, umbilical cord felt. Now what? Actually, this case, this topic has been discussed. If everybody has attended the cord prolapse lecture previously, we can move on. Next case. Stop. Previous slide. So these are the different positions where in a case of cord prolapse, we can put the mother till we are going to decide for the cesarean section. Cesarean section is the only option until and unless we are able to keep a finger and push the umbilical cord aside. But still, cesarean section is the only option for the case of cord prolapse. Next. Anybody
Dr.
wants to
Kazi.
add something? Yes, ma'am.
Dr. Kazi, Make sure
Yes, ma'am.
it is a cephalic presentation.
Yeah, I'm
Prolapse
talking
with
about
breeze
cephalic
is
only.
not so. Yeah,
No, no,
because
I'm talking about only cephalic, ma'am.
I understand cord prolapse with breach is not that much of an emergency. That is one thing.
Yes,
And
ma'am.
secondly, sometimes if you are short in staff, what you can do is gently replace the cord. Try to push it above the presenting part and put in a moist pack.
Moist pack, yes, ma'am.
Yeah.
With the
So
moist
that
pack, yes.
so
The
that
temperature, yeah.
you are free to look after other matters till you take up the seat.
Yes, yes, ma'am.
You might try to do that. Also, sometimes we advise our residents to give her atropine because as soon as the cord comes in contact with the outer atmosphere, there can be an element of vasovagal shock to the baby itself,
Yes, yes,
and we administer intramuscular atropine to the mother.
yes.
This also helps sometimes.
So in our cases like in a peripheries, what we have to do is we may be the only gynecologist, so we have to keep our head inside, and we
Yes.
just have to guide all the staff to do all the things, call the anesthetic, everything, lift the leg, and we just try that cord should go beyond the presenting part. That will be the
Yes.
dream for us in a case of cord prolapse, but many of the times it is not possible until I did one thing that in one case I did a cesarean section until spinal has been given by the anesthetic, and my hand was inside the vagina till that.
Yeah. Yes, that is the only thing you can do.
Yes,
And at the same time, because your hand is inside,
Sarfaraz.
yes,
I have done
we
one
all,
surprise, same like.
yeah, we all at the periphery have to do like this.
લેબર રૂમ માંથી જ હાથ અંદર ફિંગર વજાઈનામાં મૂકીને જ ઓટીમાં લઈ જવાનું, સ્પાઇનલ અપાય ત્યાં સુધી હાથ અંદર
ત્યાં
જ
સુધી
રહેવા
હાથ
દેવાનું છે.
કાઢવાનો નહીં. And that
but
at that time,
apply-
our teacher, I am a student of Bharti Ben Bhatt, Madam BKB ma'am, and Ajit Desai sir. They taught us that once in a while they asked us to do rapid fire cesarean section. So that type of training, in a case like a Misgaon Lada's
Yes.
technique, in this type of cases we have to use. We have to forget about the little bit tissue injury just to save the life of the neonate.
No, simply enter through midline vertical incision. No Misgav Ladakh needed. You only open 3 layers and you are on the
No,
uterus.
no, ma'am. Even with the transverse incision, the same time we will enter to the uterus. And nowadays, previously, so many people are doing midline, but nowadays, even most of the last 5 or 10 year passed out gynecologists did not know the technique of midline vertical incision for the cesarean section. It is like for them, it is like, oh, what is this?
Agreed.
Yes, ma'am. Yes, ma'am. Okay. Shall we continue, MC Patel sir? Or the panelist?
This is case of shoulder dystocia, sir, as pre-pregnancy diabetic and macrosomic baby, because
Very
shoulder
good.
didn't deliver more than 60 seconds. So
Yes,
Yeah,
yes, yes.
the case of
And
shoulder
that
dystocia.
that topic is already been covered by the previous speaker.
Yes.
Yeah. So move on to the last. If everybody is ready, continue. Fast forward. Oh, go back. Case number 5. This is a big case. It will take so much of time. It is a long case. It is a case of postpartum collapse.
Hello.
Hello, sir. MC Patel, sir.
સર રહેવા દઈએ હવે.
પરેશ સર, ચલો લાસ્ટ બધાનું એક કોઈ એડવાઇસ કહો કે કોઈ ટેક હોમ મેસેજ કહો તમારા પોતાના એક્સપિરિયન્સ પરથી, સ્ટાર્ટિંગ ફ્રોમ કેમેરા સર.
લેબર રૂમમાં સ્ટાફના ભરોસે બહુ નહીં રહેવાનું. આપણે જોતા રહેવાનું. ને ઘણી વખત આપણે કેવું છે, થોડું બ્લીડિંગ થતું હોય, સ્ટાફ ઇગ્નોર કર્યા કરે, ટ્રિકલિંગ થતું હોય. જ્યારે આપણને બોલાવે ત્યારે ઘણી વખત પેશન્ટ વધારે પડતું લૂઝ કરી દીધું હોય. બ્લીડિંગમાં એવું છે, જો તમે બહુ બ્લીડિંગ થશે ને પેશન્ટ ડીઆઈસી જતું રહેશે તો પછી રિકવર કરવું બહુ અઘરું પડી જાય છે. એના કરતા ઘણી વખત નહીં કહેતા લોકો કે આને તો 50 બીટી લગાયા, 30 બીટી લગાયા ને જો તમારે 4-5 બીટી થી વધારે જરૂર પડે તો એ પેશન્ટ તમારું રિવાઈવ નહીં થાય. પેશન્ટ રિવાઈવ 4-5 બીટીમાં જ થઈ જશે જો ગમે એવું હશે તો. બાકી ઘણા બીટી લગાવવાથી બ્લડ ના જે કોમ્પ્લિકેશન છે બ્લડ ટ્રાન્સફ્યુઝન ના એ જેટલા બધા હોય છે કે પેશન્ટ એમાં ને એમાં પછી ડિટોરિએટ થઈ જશે.
And we also must understand that whenever we are practicing, which products are readily available to use in case of emergency. Like PRP and FFP, if it is not available, then we should be very judicious to take any of this emergency at our place.
Very true.
Paresh,
પેરીફેરીમાં બી બધું કમ્પોનન્ટ મળે છે.
સર
Paresh,
વર્કિંગ ઇન પેરીફેરીમાં હું એને એડવાન્ટેજ ગણું છું. ઇન્સ્ટિટ્યૂટમાં આપણે કામ કરીએ છીએ ને વી હેવ ટુ ટેક સો મેની પરમિશન્સ એન્ડ વી હેવ ટુ કોલ્સ ફોર હેલ્પ એન્ડ ટાઈમ થોડો વધારે જાય છે. જ્યારે ઇન્સ્ટિટ્યૂટ સિંગલ હેન્ડેડ ઇન્સ્ટિટ્યૂટ હોય છે ને ત્યાં આગળ ડિસિઝન મેકિંગ આપણે પોતે હોય છે. એટલે થિંગ ગોઝ વેરી ફાસ્ટ અને ડિસિઝન બધા ફાસ્ટ લેવાય છે. અને મોસ્ટલી ઘણી વખત એટલું ફાસ્ટ મેનેજમેન્ટ થાય છે કે એ જ પેશન્ટ ઇન્સ્ટિટ્યૂટ લેવલે ઘણી વાર કોમ્પ્રોમાઇઝ થઈ જાય. કારણ કે આમાં ક્યાંક ડિસિઝન મેકિંગમાં વી હેવ ટુ કોલ સિનિયર, ઇન્ફોર્મ સિનિયર, એ બધી જે પ્રોસેસમાં ઘણી વખત વધારે ટાઈમ જશે. એટલે બધા ઓલ આર ડુઈંગ વેલ બટ સમટાઈમ આઈ ફીલ દેટ ઇફ યુ આર એફિશિયન્ટ વર્કિંગ એઝ અ સિંગલ પર્સન ડિસિઝન મેકિંગ you can take decision very fast. If you need to take help, don't hesitate. But if you are confident to work, you can take fast decision and work very fast.
Yes, Paresh, there is always two sides of coin.
Yes.
Nesargi?
And so we have to wait and we have to give time for natural labor actually. We should not interfere in between and every time doing PV or ખેંચી કરવાની જરૂર નથી. Because of that, like so many times traumatic PPH will occur. And maximum because of that only PPH occurs. Second thing, we have to train staff with protocol. At least they can inform like how much blood loss immediately they can inform. That much we have to teach them. And we have to put all protocol in our labor room with PPH and PIH kit for making.
Sushma ma'am.
I have just this suggestion કે you are correct. Sometimes પેલું hierarchy-માં decision making લાંબુ થઈ જાય છે. Yeah, that happens, but still residents are well trained, one thing. But when you are in private, you can, if you are confident, deal with difficult cases. But looking to the current scenario, મને એવું લાગે કે 2 કે 3 consultant ભેગા થઈને કરો. It reduces your personal stress, adrenaline ઓછું થઈ જાય, અને it also helps you to share responsibility.
Right, ma'am.
Answerability બી થોડી વધારે સારી થાય. It is nice if you can tackle this, but at least share responsibility. અને 2-3 જણા, at least 2 people, 2 consultants. ખાલી એક જણા બધું ના manage કર્યા કરો. It will be really very, very difficult in that scenario.
100% agree, ma'am.
Correct.
100%.
સુષ્મા મેમ એવું છે કે દરેક સેન્ટરમાં 2-3 કન્સલ્ટન્ટ એવા હોય છે કે જે દરેક જગ્યાએ હેલ્પ માટે જ હોય છે. ગમે ત્યાં PPH થાય એટલે એમને સીધો કોલ જાય.
એના માટે તો કોઈ બેમત છે જ નહીં. Some things goes wrong, call for help for sure. But when you are first person to handle the things, don't allow situation to go get it worsen. એટલે તમે ફાસ્ટ ડિસિઝન મેકિંગ થી સારું આઉટકમ લઈ શકો. અને ડેફિનેટલી વેન કંઈ પણ બી ખરાબ થાય તો ટેક હેલ્પ વિધાઉટ હેઝિટેશન.
One suggestion is કે blood loss overestimate કરો ને તો વાંધો નહીં, પણ underestimate કરો ને એમાં જ વધારે પ્રોબ્લેમ થાય છે.
રાઈટ.
અને like you very rightly said કે staff takes it very casually. They probably do not understand the severity. એટલે દરેક જણે તમારા પોતાના લિમિટેશન્સમાં રહીને પણ કોઈક સિસ્ટમ સેટઅપ કરી દેવી જોઈએ કે સ્ટાફ પેલું આમ થશે કરીને તમે લોકો you cannot reach all the places. તમારે OPD બી જોવાની હોય, આ કરવાનું હોય. It's a tough situation. પણ કંઈક સિસ્ટમ્સ એવી રીતે સેટઅપ થવી જોઈએ કે
મેડમ યુ કન્ક્લુડ પ્લસ
એટલીસ્ટ ઇવન પેલું એક આપણું સિમ્પલ પલ્સ ઓક્સીમીટર હોય ને, એ સ્ટાફને કહેલું હોય કે ડિલિવરી પતે પછી દર 20 મિનિટે લગાડીને ફોટો પાડીને મોકલી દેવાનું.
રાઈટ.
તો ટેકીકાર્ડિયા ડેવલપ થતો હોય, હાઇપોક્સિયા ડેવલપ થતું હોય તો એ ખબર પડે ને. આઈ થિંક એ લોકો ઇલેક્ટ્રોનિક બીપી મોનિટરિંગ બી કરી શકે.
Right.
તમે
આના
ઘરે
માટે
રાત્રે ડિલિવરી થાય ને તો બી એટલીસ્ટ અડધો કલાકના ફોટા હોય તો તમારી પાસે બી ડોક્યુમેન્ટેશન હોય કે યુ હેવ ટેકન ડ્યુ કેર અને
Right.
આટલા વાગ્યા સુધી પેશન્ટ સ્ટેબલ હતું.
મોસ્ટલી
Correct.
અહીંયા છે જ કદાચ કેમરાજભાઈને બી પરેશને બી ખબર હશે કે અહીંયા સિસ્ટમ મેડમ એવી છે જ કે વોટ્સઅપનું ગ્રુપ હોય હોસ્પિટલનું અને
Right.
જે પ્રોટોકોલ પ્રમાણે એમને
બધા
કીધેલું જ
આવી
હોય કે જે
જાય.
હા જે ઓન ડ્યુટી સ્ટાફ છે એ જેટલા ટાઈમમાં સપોઝ કે ઇમિડિયેટલી ડિલિવર છે તો એવરી 15 મિનિટ્સ ફોર 1 અવર ધેન 30 મિનિટ્સ ફોર 1 અવર ધેન અવરલી એ રીતે
હા
એ લોકો પુટ ઓન વોટ્સઅપ ગ્રુપમાં જ કરે એટલે એટલીસ્ટ તમારી પાસે તમે એકલા ના હો આ બધો સ્ટાફ હોય સિનિયર સ્ટાફ બી હોય મેડિકલ ઓફિસર બી જોતા હોય કદાચ આપણો આસિસ્ટન્ટ ગાયનેકોલોજીસ્ટ હોય એ બી જોતું હોય તો કોઈના બી નજરમાં આવે કે સમથિંગ ઇઝ ગોઈંગ રોંગ
કોઈક તો જોઈ
તો
લે.
હા તો
Right. Right. Right.
અર્લી મેનેજ થઈ જાય સેકન્ડ એન્ડ લાસ્ટ થિંગ ફ્રોમ માય સાઇડ અત્યારે ફોક્સી એફિલિએટેડ માન્યતાનો પ્રોગ્રામ ચાલે છે માન્યતા એક્રેડિટેડ હોસ્પિટલનો એના અંદર એ લોકો પર્ટિક્યુલરલી તમારી પ્રિમાઇસીસ ની અંદર અવેલેબિલિટી ઓફ ઓલ ધ થિંગ્સ લાઈક પીપીએચ કિટ એન્ડ તમારા સ્ટાફને જ ટ્રેન કરે છે ટુ ટેકલ સ્ટાર્ટિંગ ફ્રોમ એન્ટીનેટલ ટુ પોસ્ટનેટલ each and every aspect they are covering with a minimum of amount એ પ્રોગ્રામ અત્યારે ગુજરાતમાં જસ્ટ સ્ટાર્ટ થયો છે 50 હોસ્પિટલ ઓલરેડી એમાં એનરોલ થયેલી છે ફર્સ્ટ બેચમાં નેક્સ્ટ બેચ એ લોકો લાવવા માંગે છે તો જેને પાસે બી આટલું વ્યવસ્થિત ઓબ્સ્ટેટિક બર્ડન છે અને પોતાના સ્ટાફને એ વેલ ટ્રેન કરવા માંગે છે તો એમાં જોડાશો તો એમાં ડેફિનેટલી તમને ફાયદો મળશે હું પોતે માન્યતા સાથે જોડાયેલો છું એન્ડ last year only I have awarded as a Manyata champion. So I am going to take care of any Manyata project in Gujarat from next year. So anybody
That is
need
very good.
any help from that perspective because NABH માટે accredited થવું એ આખી અલગ વસ્તુ છે અને એમાં કદાચ આપણે બધા ના બી થઈ શકીએ પ્રાઇવેટ પ્રેક્ટિસના પણ
NABH
this
બહુ
is
serious છે પણ
હા
આ
હા
પ્રેક્ટિકલ હશે એવું માનું
આ
છું.
પ્રેક્ટિકલ છે and this is basically to train your staff to you can say the filter out the high risk cases from starting from the antenatal and how to manage the emergencies like eclampsia or everything.
Yeah. અને my one more suggestion is કે જેટલું એન્ટીનેટલ કેર આપણી વધારે ઇન્ટેન્સ ને ઇન્ટિગ્રેટેડ હશે ને એટલું પરઓપ ને પોસ્ટ ઓપ આઈ મીન ઇન્ટ્રાપાર્ટમ ને એ બધા કોમ્પ્લિકેશન્સ ઓછા થશે. આઈ ડુ અન્ડરસ્ટેન્ડ કે પેશન્ટ બહુ રેગ્યુલરલી નથી આવતા. અમને અહીંયા આ સેન્ટરમાં બી એવું થાય કે બે વિઝિટ અહીંયા લીધી, બે વિઝિટ કોઈક પ્રાઇવેટમાં લીધી, બીજી બે વિઝિટ ક્યાંક ત્રીજી ને છેવટે કોમ્પ્લિકેશન જોડે આપણી પાસે આવ્યા. બટ સ્ટીલ good antepartum care definitely helps to reduce all kinds of morbidity and mortality.
And it is always you should keep in mind you should know where to stop, not know where to jump. ગમે ત્યાં કૂદી નહીં પડવાનું ક્યાં અટકાવવું એ આપણને ખબર હોવી જોઈએ કે બસ અહીંયા મારે અટકવું છે.
Yes,
MC sir,
that
Monica ma'am.
so the right time to refer a patient and
Yes.
the right way of referring that you should have always accompanying a person who can take care of the patient on the way. Documentation of the referral process. This is really, really important. Even Patel sir will agree to me because only documentation will help you in the court of law.
Yes. And as far as transfer of any patient is concerned, so on Foxy website under title of Foxy Uniform Consent, we have prepared 30 different consent, and out of those 30 different consent, one consent how to refer patient to higher center is also there. We have given checklist what you have to observe at the time of transferring the patient to any other higher center. So you can simply download that and you can use it. As far as this Manyata project is concerned, same way Foxy had given box means PPH box and eclampsia in past, and there were good chart and it was made up from plastic, so you can stick on wall of your labor room. So in case of PPH what to do, in case of eclampsia what to do, and one box was given PPH box. If you open that very box, each and everything which is required to tackle PPH will be there in that very box, including oxygen cylinder pana. Okay, many times when oxygen is needed and you are searching for pana and precious time is wasted. So that way, that boxes were prepared from Foxy and they were given to our members. Same way for eclampsia, including Maxelf, etc., were given in that very box. Now IV Maxelf is available, so it has become very easier thing for us. Otherwise, in past we were using those ampules and we were preparing solution. So all those ampules were also provided in that very box. And in that very box, when you open that box, whichever things inside the box or list was pasted there. So in emergency, you have not to search here and there. From that very box, you will get each and everything. Say, for example, methargine, prostrodine, misoprost, everything will be there in that very box only. So one can adopt any method which is convenient to them to deal with this type of situation. Because in periphery, I have also worked in periphery before I shifted to Ahmedabad. And that is why I straightway diagnosed that case of Vajra previa. Because in Vajra previa, many a time when you do PV and when membrane is intact and you feel pulsation, then it is dictum that no rupture of membrane should be there and delivery should be before membrane ruptures. Otherwise, you may end up into torrential hemorrhage and it will be difficult to manage. So one of the cases we had faced like this in past, and that is why when Sarfaraz said that it was fresh vaginal bleeding just after rupture of membrane, so that clicked in my mind that very case we managed long back. I am talking of
Experience always matters, and old is gold.
1981, 82, I am talking of. So in periphery, we used to deal with lots of cases, and we should have our own protocol, own method of managing all this. But we should be mentally prepared also to deal with the situation, because at any time we may face this type of situation. So thank you all. Monica? Is there Monica? Yes, you can propose vote of thanks. Yes, very quickly you can propose vote of thanks and we can.
I agree too, sir, that Manyata should be taken. So I would advise everybody to take Manyata and then go in for NABH. It will be much more easier because most of the documentation gets covered. And secondly, your staff is trained clinically. Now, like Sarfaraz sir, I am also a Manyata champion and I'm the regional coordinator in Maharashtra here. They are charging a nominal fee of only 10,000 rupees right now. So it is much, much easier to get it done. And they take the training of the staff, like how to do a PV, how to take a consent, everything is taken. So everybody should take an advantage of this. So let me propose the official vote of thanks. I would first and foremost like to thank Dr. Patel sir for giving all of us as coordinators the opportunity to coordinate this program. Our chief guest, Dr. Suchitra Pandit madam, the guest of honors, Dr. Hemant Bhatt sir and Dr. Chintan Thakkar for joining us and gracing the inauguration. Our chairpersons, Dr. Rahul, Dr. Priyanshu, Dr. Uday Patel sir, Dr. Zalak Shah, Dr. Sanjay Gandhi, Dr. Parth Shah, Dr. Prakash Joshi sir, Dr. Neeta madam, and Dr. Vishang for chairing the sessions. Our speakers, Dr. Munjal, Dr. Sushma ma'am, and Patel sir. The panel discussion was the icing on the cake, moderated by Dr. Parul and Dr. Sarfaraz Kasi. Thank you to all our panelists, Dr. Ishan, Dr. Khemraj, Dr. Anand Chaudhary, Dr. Chirag Joshi, Dr. Naisargi Patel, Dr. Veera Luhar, Dr. Paresh Solanki, and Dr. Mahendra Soni. Outset, I would also like to thank Corona Remedies for the academic role, and thank you, Nilesh, for all the help at the background.
Thank you so much.
And we invite.
Last but not the least, sir, I would like to appeal to everybody to please support Patel sir in his candidature for FOXI president for the next year, requesting all of you to please vote for him.
Thank you. Thank you. And at the same time, I invite all of you for two big conferences this year. One is SOGOG on 19th, 20th and 21st December. And then in month of February, National Ishad. So Gujarat is hosting this time, Ahmedabad, and you are most welcome. If at all you are interested to be faculty, then also you can contact us. We can manage that also. And I also welcome for this series next Tuesday, same time 6 p.m. We are going to discuss one more interesting topic, stillbirth, the matter of concern. And a very interesting panel will be there and moderated by none other than Dr. Pankaj Desai. So you are most welcome to have access to that webinar next Tuesday, 6 p.m. Thank you. Thank you very much.
Thank you very much, sir, and best of luck for your tenure. We all are with you, sir.
Thank you all.
Thank you so
Thank you,
much.
ma'am.
Thank you.
Thank you, sir.
I'm ending the session.
Good night,
Thank you.
everybody.
Good night.